Good morning, everybody. Thank you ever so much for everyone being here bright and early. We have quality, if not massive quantity, and we're looking forward to a really great session this morning. Alex and I weren't quite sure whether we should be flattered or not that Ranjit decided we were either reliable stroke boring enough to chair the 9 o'clock session on a Friday morning, but it's lovely to see everybody.
Great. Well, yeah, wonderful to be here, and thank you to all our speakers this morning. I'd like to introduce Anant Desai, who's going to speak on the rationale for centralising management of rarer cancers. Anant is a consultant sarcoma surgeon at the University Hospital in Birmingham, and he's developed the Birmingham Sarcoma Service, which is one of the biggest in Europe. Wonderful to have you here. Thank you,
Thank
Anant.
you. Thanks, everyone. Good morning. I think a lot of people still suffering from the dinner, by the looks of it. Anyway, I'll get through this quickly. So my name is Anant Desai. I'm a surgeon in Birmingham, and I've done some work in the management, centralisation of rarer cancers. I'm a retroperitoneal sarcoma surgeon. So the history is, I'll do a little bit of history, and I'll tell you what we're doing in the space in retroperitoneal sarcoma. This goes back to 1979, when a group in America identified 3 groups of operations. And in those days, the coronary artery bypass graft was a big deal. And they found that in high-volume centres, you were 30% more likely to be alive than if you're in a low-volume centre. Colectomy showed an intermediate volume effect, and cholecystectomy, well, anyone could do that, so you could have that done anywhere. And they, in 1979, in New England Journal of Medicine, said there may be a case for regionalising some procedures. This is a paper that most of us have probably seen in 2002, New England Journal of Medicine, Birkmeyer, who'll come up now and again. He looked at 14 procedures, cardiovascular and cancer, 8 and 6 of each, 2.5 million patients, and all procedures demonstrated volume effect, all of them, but most marked in pancreas and esophagus, and you can see that here and here. So complex cancer surgery seems to stand out in terms of its volume and outcome effects. And you can see that the curves are really flattening for cardiac surgery as technology moves on. The conclusion is quite significant. Patients can significantly reduce their chance of death by selecting a high-volume institution. In other diseases, I won't dwell on this, in trauma, you may know that in the UK we centralised to major trauma centres back in 2012, and you can see that although things were improving, they improved significantly after that centralisation, and the speed of change improved, and that was particularly in severely injured patients, a 20% improvement in those who are most severely injured, again echoing what we see in cancer surgery. Same thing seen in stroke. It's not just about mortality, it's also about quality, and you can see that the stroke management was centralised in London and Manchester. And things were getting better anyway, and after centralisation, patients are more likely to receive evidence-based interventions like scans and antiplatelet therapy, but those patients who went to the hyperacute centres received a greater proportion of those interventions. So things got better as a result of centralisation, both out in the periphery as well as a result of these specialist centres. Interestingly, and we'll look at numbers again in a minute, and the reason I put this slide up is that as surgeons we're obsessed with numbers and we're obsessed with retaining our practice, whereas radiotherapy, they don't really mind. They just put out a service specification in 2019 that said that every consultant clinical oncologist will be responsible for 25 to 50 cases of radical radiotherapy for the less common cancers. And that just happened without really any particular consultation. And a unit needs to provide 50 to 100. And that's interesting because unlike surgery, obviously radiotherapy is every day for 6 weeks, whereas for us it's one shot. So the arguments about travelling and so on don't seem to bother the radiotherapy community. So the Dutch really have the greatest experience of this kind of thing because of their sort of very organised healthcare system and their database. And in 2006, they centralised esophagectomy and pancreatectomy, stopping all centres that were doing less than 10 a year, and then in 2011, less than 20 a year. And you can see here the blue are the centres that are doing high volume, and this is for esophagus and gastric cancer, and then the pink, so it is a low volume centre. So the reduction in number of centres performing gastric surgery, reduction in number of low volume centres, but interestingly the outcomes were mixed. Stable mortality in esophageal surgery, but gastric surgery mortality was halved. Some of this effect was due to volume, some of it may be just due to the audit itself. Pancreatectomy, however, the outcomes were more marked. 2004-2009 is again Holland. Number of hospitals performing pancreatic surgery fell from 50 to 30. Mortality halved, and hospital volume and age were significantly associated. And you can see if you're operating in a high volume centre as the reference, you are 5 times more likely to die if you're in a low volume centre. So an overall effect of 11%. It's a significant change. UK experience was more mixed. This is 2015, I think, 2016. They looked at gradual centralisation in the UK over 10 years, significant reduction in the number of centres from 100 down to 40, and the mean volume went up from 20 to 55 for esophagogastric surgery. But there was a reduction in mortality. But you can see that even after adjustment for volume, the mortality effect stays. So they say that the reduction in mortality of the study period not explainable by volume alone. What is interesting in that study is that although the unit volume went up, surgeon volume stayed the same. So I wonder whether some of this is due to the fact that because the number of surgeons went up. So individual surgeons were performing no more than they were at the start of the study. Nonetheless, Augis in the noughties decided that they would issue these guidelines, and a centre for esophagogastric surgery serves a population of around 2 million, and each surgeon, of which there should be 4, does 20 resections, and then similar for liver and pancreas, minimum of 5 surgeons serving 2 million. So they did that despite these somewhat mixed data. This is our friend Birkmeyer again. So he did another review in 10 years after the original one. And he saw, again, that there was declining mortality across the board. And that's better care, better ITU, better drugs. And the volume outcome relationship had become much weaker in cardiac surgery, as we've seen. There were certain procedures like AAA repair where there was this very significant decline in mortality, and that was due to endovascular techniques. But hospital volume did contribute to improvements in survival, and that was most marked in complex cancer surgery. So you can see esophagectomy, pancreas, and cystectomy had the biggest volume hospital effect. I won't dwell on this because it's quite complicated, but this German study tried to work out what the minimum number of patients you had to treat was to have a greater than average mortality. And then worked out from that how many patients you would save. And if I draw your attention to this, for esophagus, you need to do 22 per year. And if you do, and that means you treat, for every 47 patients treated, 1 is saved, compared to a below 22 per year. And these thresholds are quite common. Between 20 and 30 seems to be the number for cancer surgery. If you look now at, where are we? Yeah, coronary artery bypass, it's actually 475 patients is a threshold. And you need to treat 658 to save 1 patient. So the volume effect is most marked in cancer surgery. This is a study from America that says that actually quality surgery is actually, high volume surgery is actually cheaper. The mortality for high volume was lower, the complication rates were lower, non-home discharge was lower. Actually, interestingly, hospital duration was about the same, but the cost was lower, $41,000, $36,000. And the difference in price is the biggest at the highest complexity. So bigger centres do things more cheaply, partly because they get fewer complications. Now, this is probably my favourite paper ever written. So this is, again, our friend Birkmeyer. I wish I had his CV. So he again, New England Journal of Medicine, he took 20 bariatric surgeons in Michigan, and they filmed themselves doing laparoscopic bypass surgery, and it was anonymised. And then these were then rated by other bariatric surgeons in Michigan who are not in the study. And they were rated from a scale of 1 to 5, 5 being what you want to be, 1 being rubbish. And so what they found was the most skilled had the highest volume, so they did the most. And the most skilled had the fewest complications. They had the fewest complications, they had the lowest mortality, they had the lowest readmission rate, and the lowest operative time. So there was a direct correlation that was significant between operative skill of the surgeon, volume, and outcome. Finally, we're always told, before I move on to retroperitoneal sarcoma, that patients won't travel. They will not travel. Mrs. Miggins wants everything on her doorstep. And actually, that's not quite true. This is from the British Journal of Surgery 5 years ago. They did what's called a discrete choice experiment. 500 patients, healthcare professionals, members of the public. They were asked what was important. I won't go into it, but none of those groups found that distance to hospital was important in their choice of centre. They were then asked, how far would you travel? And they said, well, I'd travel an extra 5 minutes for every additional procedure performed by that hospital. I'd travel another 75 minutes to reduce my complication rate by 1%. And I'd travel 5 hours to reduce my mortality by 1%. So it's not true that patients won't travel. They just need help to travel, and that's the point. So what we're doing in retroperitoneal sarcoma, this is our service specification 2019, and it was published just up the road here at UCH by Professor Jeremy Whelan. And there were a number of things in there, strengthening the MDT, which I'm talking about a bit later on. But this is what I draw your attention to, the minimum recommended caseload number for primary intra-abdominal sarcoma per designated centre per year, 24. So you might ask where we got that number from. Well, it was controversial. It was expert opinion. In other words, we made it up. There was no real evidence. But it was still agreed by the specialist advisory groups in 2021 as something to work towards. And that was sort of 2 years after the service spec. So we met with Peter Johnson, National Clinical Director for Cancer, Bill Allen, Surgery, CRG, and they were unconvinced. And they said, well, there are some, on the background of this international data that I've shown you, you really need to show something that's more relevant to your population that justifies this 24. So we then put out 3 publications, which I'm going to share with you now. This is the first. So this is associated with centre volume allocation to curative surgery. This is in the States from our group. Observational study, 11,000 patients over 11 years from the National Cancer Database in the US. And what we do is divide centre volume quintiles, so equal groups of 5 from high to low volume. And you can see quite clearly that the high volume centres on this Kaplan-Meier have a higher survival than low volume, quite significantly. But in fact, the more important thing, not only survival, is if you look at the low quintile versus the high, 52% of patients offer surgery, 73%. So you're much more likely to be offered an operation in a high volume centre. And that's the odds ratio is between 2 and 2.5, so twice as likely to be offered an operation in a high volume centre. So centre volume associated with greater allocation to surgery and survival, twice as likely on multivariate analysis to offer surgery, and as usual in the US, non-white, low education, uninsured patients less likely to be offered surgery, and also more likely to go to a low volume centre. So that was the first thing. So we could show that the high volume did better. We could also show that you were more likely to be offered an operation. And in other studies, in extremity sarcoma, bone sarcoma, you're also likely to have a bigger, higher grade tumour. So it's not that we're being more selective. This is a second study that we did, 2023, yeah. So assessment of intercenter agreement across MDTs. So what we did is we took 21 patients who were treated at QE in Birmingham, anonymised them, and then sent out the scans to all of the specialist centres in the UK, of which there are about 15. And these are the scans. There was no right or wrong answer. And what we did was we asked them, is it operable? And if it isn't operable or you want to give other treatment, what would you give? We looked at variability. So this is a waterfall plot. So some patients it was easy. So we said, can you operate? And all these people said yes. But then you can start to see left field behaviour starts to creep in over here. And of the 21 patients, 12 were deemed resectable or unresectable depending on the centre. So, I mean, all of these, I mean, this chap here could have had a 50-50 chance of being an operation or not. This one, there's one centre that said yes and everybody else said no. One said don't know. So, I mean, that's 50. So I always find this remarkable. So half for people, or more than half, in fact, could have gone either way. We then said, well, what would you give if you weren't going to operate? So these are the patients who everyone agreed on. But then again, left field behaviour starts creeping in over here. And you've got patients like this who could have been given anything from attempted curative surgery to best supportive care. So again, 11 of the 21, 10 of the 21, beg your pardon, received either potentially curative or palliative treatment. So this paper took a long time, actually, to publish, largely because it was really controversial. Many people actually withdrew their support after it was submitted. So we had to ask for it back from the BGCS to take a load of authors off, which I've never had to do, and then resubmit it. And we were thankfully allowed to resubmit, but it was very controversial. So then finally, I think I'm doing okay, yeah, is primary retroperitoneal sarcoma, comparison with survivals. So then so it was about data. So how are we going to persuade people that they've got to stop doing these operations? So we looked at retroperitoneal sarcomas diagnosed in the UK between 2013 and 2018. And we use a definition from an international group. Sarcoma centres defined by those hosting a multidisciplinary MDT, the MDT, which is about 15. And we had it funded by Sarcoma UK to have an analyst, because you can only really get this data with a full-time analyst. So nearly 2,000 patients in those 6 years. 60% underwent surgery, and we still don't know why as many as 40% did not, and that's quite a big number in comparison to international studies. We're trying to look at that. It's quite a difficult group to identify in the data. Mean follow-up was 26 months. Overall survival was 82 and 58% at 1 and 5 years. So this is specialist versus non-specialist. So if you go to your local DGH and have your sarcoma out, then you're going to die. 5% of people will die at 30 days compared to 1.78. 1 year, 71 versus 86%, and the 5-year overall survival advantage is nearly 16% going to local hospital versus UCH or the Royal Marsden. That's not entirely surprising. And going to your local hospital, you're not going to have a multivisceral resection. Also, although the difference still exists even when we correct for confounders, a lot more patients were presented as an emergency in the DGHs, presumably just turned up in A&E on a Saturday night bleeding. So big difference. But we extended the analysis. So specialist versus non-specialist, 9 a year versus 1 a year. But then if you look at the specialist centres, there's a dichotomous group in that the 3 top centres did 50% of the UK's retroperitoneal sarcomas, and they did an average, interestingly, of 24 per year, just how it worked out. And the other 50% were done in the other 12 minutes, average just 6 a year. So there's 2 very different groups among specialist centres. So there are 3, 2 in London and Birmingham, and the other 12. And then now you see that, okay, the difference between QE and London and DGH is obviously marked, but then these are specialist centres, these are big hospitals, Nottingham, Liverpool, Leeds, and their results are somewhere in between and not as good as the high volume centres. So what you can say is that, as I said to you, the 30-day mortality is very different between high-volume specialist centre and non-specialist, but there's no difference between high volume and low volume for 30-day. That's because these are all big hospitals with ITU and all the rest of it. But when you look at the overall survival data, at 1 and 5 years in a high-volume specialist centre is 87 and 63, and it's 85 and 52%, so 12% difference between high-volume specialist centres and low-volume. That's as it is at the moment. What happened next? Well, we wrote an editorial for the EGSO saying that we think that there should be centralisation to high-volume centres in the UK. Again, attracted some comment from the US saying that one size does not fit all. Texas is the size of Western Europe. How are we going to manage that? And my answer to that is, well, you just need 10 or 12 centres in Texas, not 200, which is something like what they are. I mean, there are over, I think, 8,000 centres recording activity for retroperitoneal sarcoma in the US. It's been incorporated in the UK guidelines from the BSG, British Sarcoma Group. And interestingly, an international study looking at centres of high and low volume specialist centre found again that 24 was the number done internationally by high volume specialist centres versus low. They actually picked a cutoff of 13 to please the Americans because it's a much lower threshold and much more achievable for American centres, where in fact the median number done by high volume centres across the world was 24. So finally, where do we get to? I'm a bit ahead of time. A letter has finally gone out, 20th of May, so just a few weeks ago, after 7 years of working on this, from the Director of Specialised Commissioning to all the medical directors. Data suggests an opportunity to improve outcomes for patients that require radical curative surgery for RPS. And that's going to be done in 2 stages. So confirm which providers are commissioned, so that map essentially, although it's not quite as clear as that map makes it look actually. Ensure volume compliance in those commissioned centres. Review procedures carried out outside commission providers, because still about 20% of patients are being operated outside of specialist centres. Ensure that sarcoma activity is in commission centres only. That's a no-brainer. But then the next point, is that these people, Cancer Programme of Care, Cancer Alliances, SAGs, and commission providers work to develop proposals that will result in higher volume compliant surgical services. That says a lower number of higher volume centres over the threshold of 24. And having taken years to get to this point, they now want it all done within a year, really, 3 to 6 months for stage 1, 3 months for stage 2. It's not very clear, but then there's this governance framework implementation period, which I don't know if it's included in that time or whether we add that on, because that could take another year. But that's kind of where we are. So hopefully in 12 months we'll have changed things. Okay, so in conclusion, so I rattled through that a little bit because I was told I need to keep to time. So there is a clear relationship between volume and outcome, which provides this rationale, which is what I've asked to talk about today, for centralisation. It's particularly strong in cancer surgery. That seems to stand out even amongst cardiac and other surgeries. Cancer surgery shows a very strong relationship between volume and outcome. Institutional volume is important, but actually I think individual surgeon volume is equally important in this, and I think it explains some of the variations that we've seen in the publications over the years. I think in retroperitoneal sarcoma the numbers are too small really for us to want to dictate individual surgeon volume, but I think we can certainly say that 24 or mid-20s is where we should be, and that's where our service specification says that we are. The case is strong in RPS, leads to service reconfiguration in the next 12 months. Thanks very much. Any questions?
Cool. Anna, thank you for such an eloquent and clear description of your journey in sarcoma services. It's been obviously hugely evidence-backed and really very convincing. Any questions from the floor? Joe?
So I think we beat ourselves up quite a lot in gynae oncology because we centralised our services to levels of more than that back following the IAG guidance in 1999. I think we still beat ourselves up. And what the data now show is that from the most recent National Ovarian Cancer Audit, that actually there wasn't, given that we're all now in sort of centres, there wasn't any association between size and 1 year survival.
Okay.
Because I think, most centres, I think, will be doing more than 25 cases a year. But what the data do show is that if you're diagnosed in a unit, not the centre, you're much less likely to get treatment. So how big is too big?
In terms of centre, yeah, I think there is a plateau in terms of the gain. It's difficult to identify that, and it varies by procedure and by disease. I don't know in retroperitoneal sarcoma because I've shown you all the data that there are, to be honest. Extremity sarcomas are much more common, and again, it's very difficult to tease out where the plateau is. But certainly in 1 or 2 of those papers, there is a sense that once you get to a certain level of volume, the gains are getting quite small, and I suspect that is related to the procedure, just in the way that we see that cardiac surgery is now different to cancer. So do you have a volume threshold in gynae cancer for a unit?
No, not at the moment.
And you have gynae cancer centres, right, that get referred in, sort of hub and spoke.
And subspecialist training that people have to go through.
Right.
So what the Cochrane review that was done a few years ago showed that what mattered was that you were treated by a specialist gynae oncologist, and other than that, size didn't matter quite so much.
Okay.
But it was the specialist surgeon that really mattered.
The chemotherapy and radiotherapy and those things can be given peripherally, or the patients need to be treated in the centre. They basically be treated peripherally, right?
Yeah, they can be treated peripherally.
Yeah,
I mean, they're often decided by the centre.
Absolutely.
Yeah. So we have a similar thing where certain aspects of sarcoma care can be outsourced, if you like, but the decision is made by the MDT, and then the patient has their chemo radiotherapy locally. But that radiotherapy IOG unfortunately makes life quite difficult for all of our patients for radiotherapy. They have to travel now.
I work in New Zealand, and we are very centralised in a similar way to NHS, but there's only 6 of us for the country.
Sorry, I didn't catch where you were from, sorry?
New Zealand.
New Zealand, yes, okay.
And at the moment, there's only 6 of us, which means that because we're only 2 centres, we've been victim of our centralisation.
Yeah.
And therefore, the volumes mean that we've heightened the threshold at which we're taking people, and we have to bounce back a lot of people. And there's publication already from Europe saying that if you become ultra-radical and always aim for a good surgical results with no residual disease, you will let people down that may have benefited from surgery, which has been proven in ovarian cancer to still be of benefit if you go to less than 1 centimeter residual disease. And we've ultra-selected because of the volume and the restriction and the overall international shortage of gynae oncologists. And therefore, we've gone full circle.
Yeah.
So we're actively recruiting, but this has been a problem because this data has been published in gynae oncology from kind of 2002. There was this massive meta-analysis that showed that every 10% improvement in zero residual disease improved survival by 5% or something. So in the last 20 years, we've all very much centralized and prohibited other people to provide these surgeries. But we haven't made enough of us.
Yeah, I mean, you have to be careful what you wish for, of course, and I'm told that quite a lot. It's easy for me. I'm in Birmingham, and you know, we just build the empire and keep building the empire, and it's fine. But I do understand there are international restrictions. I mean, we have had a fellow with us from New Zealand who's gone back, and whether she'll set up a centralised unit in one of the centres, I don't know. But I have an idea about New Zealand because she's shown me a map and shown 2 islands, and it's quite a long distance and really for New Zealand you probably only need 1 centre actually for retroperitoneal sarcoma, but you end up having 2, which is obviously what you've done. But I do understand you can be too purist about this, and there are real world pragmatic issues. That doesn't apply in England. The distances are not great, and there's no reason to ignore these data and make an argument for less radical surgery.
And patients want to travel, so we've established a national model with patient advocates, and they've said we don't care.
Want to.
We just want to be where the experts are.
They will travel or won't?
They will.
They will.
So
they will.
They've said yes. Please put us with the best quality care.
Yeah, absolutely. And that paper very clearly shows it. But what I get when I talk to sarcoma surgeons or anyone else is they won't travel. Mrs. McGee's won't travel, and it just isn't true. What they find difficult is the expense, is the car parking, and that. And if we help them with that and the accommodation, then they that's fine. What they complain about is getting to the hospital, not the treatment when they get to the specialist centre. And that's very clear recently in a Sarcoma UK publication that we've been involved with.
Thank you. Anant, I wanted to ask you a quick question. You touched on radiotherapy and the fact that wasn't super specialised. That's also a one-shot treatment. You don't get another lot of radiotherapy. Do you think, based on the evidence that you've presented, albeit in surgery, that radiotherapy should be super specialised for sarcoma as well?
They've done it in... they're moving towards that, aren't they? They're saying for rarer cancers you need to have done 25 to 50p. I don't know where they get those numbers from. No data there. So they're moving towards it. I think paediatric radiotherapy now has been centralised in a similar way. I can't answer the broader question. I don't know. I mean, to me, it's just shining a light on it, isn't it? But I suspect it will go the same way. Paediatrics generally tend to lead the way, don't they? And they're centralising very much in a very similar way. So we're going to maybe try and use that service model. People say, well, children will travel. Well, will they? Because they've got, their parents have got to take them. They've, often got siblings. So why would children travel any more than, than a 75-year-old who's fit? So the travel argument just doesn't hold water for me.
Sure.
Very quick.
Yeah, very quick. Just moving away from centralisation into that great slide on the heterogeneity of surgical decision-making across MDTs.
Yeah.
Is there a way, as a community of sarcoma surgeons, you've been able to benchmark MDT decision-making across MDTs, or make efforts to reduce that heterogeneity? Because I think that's something that we probably see in ovarian cancer.
Yeah.
You get into silo decision-making within your MDT.
Yeah.
And somebody else will come along and say, no, we need to make a different decision.
So that's a really good question. We have done a benchmark study. The problem is it's rare, and we don't. The benchmarks for surgery certainly are not established at all in terms of multivisceral resection, what organs to resect, and there is debate about that. So unfortunately, because of the rarity of the disease, it's difficult to issue guidelines or benchmarks on how we don't even really agree on which patients should have preoperative chemotherapy. The Europeans give a lot more than we do. Radiotherapy, there's a trial that says it doesn't work, so that's easy. So, but it's absolutely the way we should be moving. And out of that study, we said that we couldn't do it by volume because it would have been interesting to see what the low volume centres recommended, whether they were a bit more windy about offering surgery or not. That was obviously the point of the study, but it got too controversial. What was I coming to? Yes, we said that if you were turned down for surgery in a centre, as a patient. The charity were offering to have you, well, we were encouraging people to be referred to another centre, a higher volume centre for another opinion. Thanks.
Wonderful. Well, Anand, thank you so much
Not at all.
indeed. Fantastic lecture. And,
Thank you.
Really appreciate it.
Thank you.
Thank you.
So it's now my great pleasure to invite Dr. Gerald Lipp to talk about gynecological AI imaging and lessons that we can learn from breast AI. He is the clinical director of breast screening in North East Scotland and was the principal investigator in the Gemini prospective evaluation of mammography and AI. Thank you ever so much.
Super. I'd now like to welcome Professor Hashim Ahmed, who's going to talk to us about screening for prostate cancer vis-a-vis gynecological cancer. Prof. Hashim is an expert in prostate cancer diagnosis with an extensive research portfolio, who's based at Imperial College London. Thank you so much.
Thank you very much. Thank you for having me, and thank you to the organisers for inviting me. So I think we're about 15 years ahead of sarcoma surgery centralisation in urology, and we're about 30 years behind breast cancer when it comes to prostate cancer. So we're in the middle in terms of the innovations that are going on. We're all biased, and I am not short of my biases. Within Imperial, we have a very large portfolio of studies and really looking at changing and transforming every bit of the pathway. But today, I'm going to touch on screening, which I'm sure those of you who've seen the PR will know that there's a huge amount of political pressure on the National Screening Committee at the moment to allow for prostate cancer screening. But there is a big problem, and we don't want to try and make the same mistakes that breast cancer made in terms of its screening program going forward. This is, up until about 10 years ago, this is what the pathway involved. So a man would have a prostate-specific antigen blood test, and if that was above 3, how he got that blood test is variable. Health assessments offer it routinely, but in the UK, men can request it. So the uptake of a PSA blood test during the lifetime of a man is estimated to be about 30%, but the overall testing rate is about 5, maybe 10%. So very low levels of PSA testing. If you had a PSA test, you'd be referred into hospital and you would have a transrectal systematic, aka random biopsy, because nobody knew where the tumors were in the prostate. It was ultrasound guided, and you'd throw in 12 random biopsies, needles into the prostate in the hope that you would hit the area of cancer. And it would be through the back passage, transfecal, no attempt to clean it. Some men wouldn't even be given local anesthetic, and the sepsis rates were high, the miss rates were high, the misclassification rates were high, and once you found cancer, because you didn't know whether it was important or unimportant, you would say to the man, I think you'd be better off having treatment, and that treatment was debilitating. 10 years ago, we in the UK led a really big study validating the role of doing an MRI scan before a biopsy. And that allowed us to find men who needed a biopsy, so biopsies were reduced by about 40%. We could target the area that looked suspicious. They weren't always cancer, but we were much better at detecting what we thought was an important cancer. And as a result of that, we were much more confident in offering active surveillance, so monitoring disease, which I know is an emerging trend in breast cancer, but not quite there yet. But we're really good at doing active surveillance for low-risk disease and even some medium-risk disease, because if we took a third of the male population above the age of 50, if we took every man above the age of 50, a third of them would have little bits of prostate cancer in their gland. And so the old adage that you die with the disease, not from it, is still very pertinent. And over the last 10 to 15 years, again, really flying off the coattails of lumpectomy in breast cancer, looking at treating just the tumor. So tissue preservation, surgical oncology is all about margins, can you contain the margin to the lesion and a few millimeters around it rather than the entire prostate, because treating the entire prostate has significant impact. So that's where we've got to over the last 10 years. And there is now a push, because we've made huge strides in that pathway in secondary care. Everybody's arguing that the equation has changed, that risk-harm benefit ratio has shifted towards favoring screening. But there are some problems. So the UK CAP study, this is a large randomized controlled trial using a Zelen design, offered men who were in the intervention arm a one-off PSA test, so there were no repeat testing of men, and they found at 16 years a tiny statistically significant difference in cancer-specific mortality. Certainly not the scale that we would want to advocate for screening. Criticisms: there were no regular, routine, repeat testing. Other criticism that it's used the old pathway, the rubbish biopsy, through the back passage, and therefore we were not diagnosing correctly, we were not treating appropriately. The USA PLCO study, which, and that was the prostate wing of it, they looked at lung and ovarian as well, showed that there was no difference in cancer-specific mortality from screening and routine screening. Big problem in this study is in the US, this was a patient-level randomization, not a Zelen design, and therefore the control group, knew that they weren't randomized to the intervention arm, and they all went off and had a PSA test. And we think the contamination rate in the control group is about 80 to 90%. And so it were basically both arms. One was organized PSA testing, the other one was disorganized, but it was enough disorganized PSA testing to remove that delta, we think. And then this is the study that everybody pitches. This is the European screening trial using a Zelen randomization, so the contamination was low in the control arm. They had repeat PSA testing every 2 years, and they did use the rubbish transrectal biopsy, but they did find a survival improvement in screening. The conclusion of the paper itself is that the harms of screening were too high. The rates of biopsy were high, the rates of treatment and therefore over-treatment and treatment-related harms were high. And therefore it didn't really justify doing screening. But there is a mortality improvement. The other issue with this study is that it was supposed to be a multi-center, European-wide study. And they excluded France due to, we don't know what, some data irregularities. And the benefit was only seen in 2 Scandinavian countries and not in the other countries. And so is there some issue around the homogeneity of the genetic cancers that we were seeing in Scandinavia that was different to the rest of Europe? So significant uncertainties. But when a man tests positive with a screening PSA, again, do we have a good test to find the cancer? So this is an MRI scan, it's multiparametric. It was developed as a result of looking at neuroimaging, where they were using diffusion and then contrast, and about 20 years ago people started to experiment with imaging the prostate with multiparametric imaging. And we could now start to see tumors, whereas previously we were throwing the needles randomly into the prostate. And the question is, can we replace the PSA test and go for a mammogram type or a prostagram paradigm in screening for prostate cancer? And this was a small study, 410 participants invited from the community to have a PSA test, have a prostagram MRI. It was blinded, so the patient didn't know, the participant didn't know which triggered a recommendation for biopsy, and we found that we were picking a lot more significant cancers when the PSA was less than 3. So the PSA threshold of 3 was pretty arbitrary when it was set about 20 or 30 years ago. You have to set it at some level, and in fact PSA, as some of you might know, was developed as a disease monitoring or post-treatment monitoring test, not really designed for diagnosis. So the PSA test possibly is rubbish as well. So you have a rubbish test, followed by a rubbish test, followed by a rubbish treatment, and everybody's going around advocating for screening for prostate cancer. And the rubbish treatment, unfortunately, has been going on for about 20 or 30 years, and I do wind up my colleagues around the world nowadays, but nobody stands up and challenges any of this. We do know treatment for advanced disease benefits in terms of survival. So this is the Scandinavian SBCG4 study. This was 2 or 3 decades ago, and these were men diagnosed with a finger test, predominantly a nodule, not PSA screening or PSA testing. So quite advanced disease that you could actually feel, and you can see there is a mortality improvement from treating by removing the entire prostate compared to active surveillance. So everybody goes for this study, but they ignore the PIVOT study from the US, randomized controlled trial in the PSA era. So when you diagnose disease early, you don't really show a clinically significant, a statistically significant improvement in mortality. There may be a parting of the curves, but it wasn't enough to hit statistical significance. And then this study from the UK. So the UK CAP study diagnosed prostate cancers. They then asked those men, are you happy to be randomized between active monitoring, where we'll just monitor your disease with PSA test. At any point, if we think things have changed, we'll rebiopsy, and if things have really changed, we'll treat in a curative form, so not watchful waiting, which is a palliative intent. And the second arm was radiotherapy to the prostate, the third arm was prostatectomy. And there are actually 3 lines on that left side curve. They just don't part at all. There is some benefit in treating in terms of metastases-free survival, but it doesn't translate to a cancer-specific survival. So when you find disease really early, even up to a 17-year follow-up period, you show no improvement. So we're treating the wrong men. We're not concentrating our efforts. And even if that 5% mortality improvement was real, which it probably is in some subgroup of men, the impact from treating the whole prostate on neurovascular bundles, on urethra, on sphincter muscle, on bladder, on rectum is horrendous. And we now have data from UK and the US showing that leakage risks needing to wear at least 1 pad a day has been significantly underestimated by my colleagues who do prostatectomy surgery. People were being quoted 5%. People were being told, oh, if you wear a one pad, it's just a security pad, you're not really leaking. If you ask those men, are you leaking? They'll say yes. Erectile dysfunction. The earlier you find disease, the more misery you cause for all age groups. Men value sexual function quite highly. They may not talk about it openly, but they do. And then rectal toxicity. Radiotherapy has a 15 to 20-year increase, slight increase in rectal tumors, in bladder tumors. So again, if you find these cancers very early, you start to cause all of these issues. And again, there is a recurrence risk. So again, a lot of patient advocate groups, often filled with men who have metastatic prostate cancer, by the way, say, well, surely saving lives takes absolute precedence over everything else. you saw a discrete choice experiment from the first talk about what patients really think. This is a discrete choice experiment of men newly diagnosed with prostate cancer, showing that they are willing to trade off survival at over a 10 to 15-year period for improvements in erectile function and improvements in urinary function, to an extent that that trade-off will wipe out any survival benefit that they might get from the treatment. So men are, on average, obviously the extremes, there are some men who won't accept any treatment, they'd rather just die. Some men will accept absolutely all of the side effects, they just want the prostate out, but the majority of men are willing to make those trade-offs. So I pointed to active surveillance earlier, and we've hinted at that. So we are doing much better in that. So if we find low-risk prostate cancer, low-grade disease, and some medium-risk cancers which progress very slowly, the natural history is very slow in a lot of men with medium-risk disease, and in low-risk disease, if it's truly low-risk, it probably just sits there and does nothing. So we are much better than the US. The US has rates of active surveillance of about 10 to 30%. In Scandinavian countries, rates of active surveillance are similarly high. The rest of Europe is similarly bad as the US. So there's a lot of heterogeneity. People point to cultural issues, but actually that's also nonsense. It's that first consultation, you know, Mr. Patel, you have prostate cancer, I'm really, really sorry. Or, Mr. Patel, I've got a bit of bad news, you've got prostate cancer, but I've got some really good news as well. This isn't going to kill you. This is just going to sit there, we can watch it. So there's a real difference in how you pitch that first diagnostic consultation. There are some outstanding issues, though, in the UK. This is the 90% of low-risk men initially choose to be on active surveillance. My worry is that this is a cancer waiting time target thing, that the minute you can tell the cancer waiting time czars that patient has chosen active surveillance, the clock stops. The question is, what happens to that man over the following year? Do they stay on active surveillance? A lot of my colleagues do a PSA within 3 months after a biopsy, which inevitably means the PSA goes up because of inflammation and bleeding. That man, when he gets his PSA at 3 months and it's gone up, will be absolutely terrified the cancer's changed and will probably choose treatment. So there's a lot of nonsense that happens after that initial thing that we haven't quite teased out yet, because the National Prostate Cancer Audit, which reported that 90% rate, hasn't looked at how many men actually stay on there. And we don't know exactly how many men with tiny medium-risk cancers stay on active surveillance as well. Over the last 10 years, we've expended so much research, and we've changed our pathways. We've taken away MRI capacity from sarcoma surgeons. We've taken away MRI capacity from gynae and ovarian imaging, from MSK imaging. We have annoyed everybody with the change in the pathway to MRI before biopsy, because we are such a big cancer load. It takes precedence over everything else. That's not my decision, but it is what it is. So we expend all of that energy doing an MRI scan. We find a target in the vast majority of men. We find that that target is the only cancer, and across the UK, if men have significant disease, they have surgery or radiotherapy to treat the whole prostate. So we throw away all that information and we just deal with the prostate in its entirety. And in a future screening program, I've made it very clear, I'm very passionate about this, that is not going to happen. And the reason it's not going to happen is because over the last 15 years, we have, again in the UK, as a result of being able to see the tumor, we can start to treat it in a focal manner. It's not quite a lumpectomy, but it's the equivalent. We can ablate it with HIFU or cryo or irreversible electroporation. There's a whole catwalk of new modalities and companies coming out in this field to try and ablate individual areas of cancer. And you get I used to say 5 to 10-fold, but it's probably a 5 to 20-fold lowering of side effects which is not surprising. You don't damage the majority of the nerves, you stay away from the sphincter muscle, you don't damage the rectum, and so far over a 10-year period, survival, not surprisingly, is close to 100%. Recurrence risk is going to be slightly higher. You've got the recurrence of the original tumor. Surgical oncology is all about margins. The tighter you get, the higher the recurrence risk. But you can go back in and ablate again. And you've got the recurrence, or not recurrence, but the development of new lesions, de novo lesions, in the untreated tissue, which is about 5% so far, so low. And when men are offered this in centers where it's been done, there's only about 4 or 5 NHS centers that routinely offer it, 95% of those men will choose to have focal therapy. So we think about 12,000 men every year should have it. At the moment, about 800 do. The reason those other men don't have it is because they're not told about it. And then screening is going to have a problem because drugs have got better, radiotherapy has got better for advanced disease. So over the last 10 to 20 years, the life expectancy for advanced disease, metastatic, locally advanced disease, has massively improved with those innovations in drugs and radiotherapy modalities. SABR, treating the Mets, and actually in the last 5 years, that median survival has gone up to 6.5 years. So we're making strides all the time. And that improvement in median survival for advanced disease might wipe out any impact of screening that we see. Might. I don't know. Now, some people say, well, it's a miserable diagnosis having advanced disease. But the National Screening Committee have made it very clear that they want to see a mortality benefit. They will not approve screening on the basis of metastasis-free survival. And then screening is expensive. Breast cancer has, screening absorbs a huge amount of money. It's a legally mandated program. If we screened with MRI scans, then if you think you have a problem with mammography reading capacity, this will overwhelm the system. So we're going to have to get those innovations in AI reading developed in parallel, and there are moves to that. So all of that contradictory information means that we do not meet the Wilson and Younger criteria. We just don't. And there are too many uncertainties. So Prostate Cancer UK and the UK government, NIHR, have awarded 42 million for a new screening study in prostate cancer. This is a large group, and these are my colleagues who are involved in the study. And it's a 3-stage design. We're going to run the first stage looking at multiple ways of screening as a cross-sectional diagnostic study. We are going to collect tissue and fluidic samples, and we're going to do some initial cost-effectiveness modeling. And we're also critically going to evaluate different ways of randomizing, because contamination is a big, big issue in any screening trial. And in a screening trial where men can readily access a blood test freely, it's very cheap if they want to get it. GPs have to offer it if the patient asks for it. So contamination is going to be a big issue. So we're looking at different ways of randomization. And then we will pick a favorite, if there is a favorite intervention, and go into a long-term study. So I won't go into the details of this, but we're looking at a Zeland design. We're also looking at a design where we will ask men in the community to participate in a research cohort, and if they say yes, we will then randomize between control and different prostate health checks. And we'll see what the contamination rates are, we'll see what the acceptance rate is, because the acceptance rate is also quite variable. Again, not too much detail in this, but different thresholds of PSA blood test to trigger a prostogram, or prostogram everybody, or polygenic risk score to determine what the screening interval should be. A lot of my colleagues have invariably responded, and these are just some of the responses. We support Transform, but we need screening now. We can't wait 20 years. There's been a lot of publicity around screening, and so all of the stakeholders, including the British Association of Urological Surgeons, fear missing out on that political push, and they don't want to be on the wrong side of history. Some people think the whole trial is a waste of time. Screening is never going to be shown to be effective. Obviously, plenty of enthusiasm, and there are some who want to stop it. Because if it starts, then they know the screening debate will have to close until Transform finishes. So they want to get screening in. They're applying huge amounts of pressure on the NSC. You can't believe the amount of pressure they're applying to that committee. And so I'm fearful there may be a shift, but for political reasons, not from the data. And so this is why they think we're going to delay screening by using this Transform study, but screening is not supported. I'll quickly move on. So just the last couple of slides. Men, when they're approached in a screening trial, in the UK, about 20 to 30% say yes. So the majority of men, when you ask them, do you want to be screened for prostate cancer, don't say yes. And depending on the acceptance rate, we might end up with a 500,000 participant study, or if we're lucky, we'll get to the 200,000. So the acceptance rate is a massive, massive issue. So Transform will try and stitch together all of those competing issues that have come across over the last decade to 2 decades, and try and bring some sense to the overall impact that might occur from within a formalized screening program. Thank you very much.
Prof, thank you so much for a really fascinating overview of the history and the current sort of situation with prostate screening. You didn't mention Chris Hoy once, but are there any questions from the floor? Andy.
Yeah. Thank you very much. That was brilliant. That was really brilliant. So I spend a surprising amount of my time nowadays turning up to meetings about PSAs because I'm the lead clinician for cancer. And I spend even more of my time looking at urology backlogs, basically. So I've got a couple of things, really. My main question is, do we have decision aids for helping people make decisions? Because at the moment, I have patients which are bouncing between urology clinics and clinical clinics to discuss the various options. And is there anything about bringing all those options and new options which come through to patients to allow them to make that decision in a slightly selfish, more streamlined way than we have at present? And the other two questions, which are around the outside of this, are, do we need to remove prostate cancer from some of the cancer waiting time targets, in so much as it drowns them and it seems to be unhelpful? And how do we resolve this issue with about 30 to 40% of all the backlog everywhere is all urology, isn't it? And pretty much all of that is prostate, which is eating into other challenges for urological surgeons, kidneys, bladders and stuff like that, where the harm comes from.
Yeah, I mean, I agree. And some of my colleagues are going around saying, oh, we can cope with screening, just bring it on. I was like, you can't cope with what's going on at the moment. Screening in prostate cancer would collapse. We're broken at the moment. It would literally collapse every single urology department in the country. So we're struggling, and every time Chris Hoy or somebody else, you get these big peaks that we just can't take into account for. And we can never catch up. Decision aids, there are research areas going on in this. It's really complicated. The vast majority of men, you can have active surveillance, you can have prostatectomy, you can have radiotherapy. There are 3 different forms of radiotherapy. You can have hormones with the radiotherapy. You can have hormones, after radiotherapy. You can now have focal therapy. Some of my colleagues around the country refuse to put focal therapy into those decision aids. So you get a ridiculous situation where one decision aid has focal therapy and another one doesn't. And we're all biased. We're all made our careers in the individual treatment that we have. And I'm afraid, is the patient at the center of it? They should be, I'm not convinced they are. What was the other question? Oh, cancer waiting times. So over the last 15 to 20 years, as far as I can remember, the NHS England and the cancer czar before that were asked to remove or consider removing prostate cancer from the cancer waiting time targets. And each time they refused. They said they got the clinical arguments, but the political arguments were strong. The minute you take it off the cancer waiting time targets, it becomes a deep priority, and it will then become under-resourced, is the concern, and the charities would destroy you. Any political party which does that would just get destroyed. So it's just not worth it. The only compromise they came up with 5 years ago was that in men who had an option of active surveillance, but were considering their options about whether they should treat or not treat, you could make a decision for active surveillance, and that would stop the clock, and you'd have 3 months in which you would then have to treat. So that's the only compromise. And then the other compromise, which I pushed quite hard for, is that men who are diagnosed with prostate cancer who go into a treatment trial come off the pathway the minute they sign the consent form. And that's helped recruitment into those studies. But the NHS England refused to make that same decision for diagnostic studies, which I find which is annoying.
Yeah, no, it's a fascinating situation because probably prostate cancer is my number one priority, and it's so low on the list of things which I am more worried about. I've got lots of other cancer which I'm worried about, but prostate is at the top of all agenda in every meeting.
Yeah. You would be foolish to upset half the population.
Super. I think we've got time for one more question. Katie, please.
Thank you. That was brilliant. I'm a cancer geneticist, and so I'm interested in what you've put in terms of the PRS stratification, and wondering what your views are around kind of molecular stratification and other kind of intermediate risk or high risk genes, and whether that will be pulled out in the study, and whether different paradigms do apply to those with enhanced genetic risk.
Yeah, so thank you. So polygenic risk score, ROS-EALS, as you will know, has done a huge amount of work on this. There is clearly going to be a role, and we're just trying to tease out. What we're hoping to do in men who consent for the fluidic samples is that in all of those other arms, we do a polygenic risk score as well, so that we can try and tease out how it fits. Whether it fits in its own arm, I'm not sure. We'll see what the data shows. In terms of tissue genetic markers, all of that research that has come out and has been commercialized through some, Decipher, Prolaris, others, has been based predominantly on the rubbish biopsy. So once those tests get validated against an MRI pathway, they struggle. And all of the fluidic markers for diagnosis and prognosis and risk stratification also struggle. So MRI is really, really powerful. And then once you get an accurate biopsy, Gleason grading is really powerful. And so the companies are struggling. And so I think there will be a role, but there will be a role in that sort of low to intermediate interface and the intermediate to high risk interface. In the future, we may be able to stratify better that large group of medium risk disease, but they are really struggling. If you can see a lesion, that visibility of a lesion on MRI trumps almost everything else. It's extraordinary.
Thank you. Thank you so much.
Thank you.
Really
Thank you for having me.
appreciated. Thank you very much indeed.
And it's now my pleasure to welcome Dr. Katie Snape, who's the lead consultant for cancer genetics at South West Thames Centre for Genomics at St George's. She's going to talk about the resource and implications for genetics on non-gynecological cancer services.
Yeah, thank you so much. It's a real pleasure to be here. So I also am the chair of the UK Cancer Genetics Group. So that's a sort of multidisciplinary organisation to improve care pathways for people with enhanced genetic susceptibility to cancer. And I have recently undertaken a secondment at Genomics England as well, thinking about a population health screening programme and looking at ways that that might be delivered safely and with the highest sort of clinical impact. I want to talk, first of all, just to set the scene around the 2 genomes of cancer patients. I'm going to then just touch on the national landscape of genomic testing for cancer patients, both now and what is imminently happening in both the short and medium term, and then think about what impact there is going to be of this massive politically and clinically driven expansion of identifying individuals with enhanced genetic cancer risk for gynecological services, and look at that now and in the future. And I just wanted to start with this case study. It's not a gynecological cancer, but it is a breast cancer, which is obviously very common. And this is the type of patient that traditionally I would have seen in kind of clinical genetic services and now would be seen in mainstream services. It's a young patient. She's under 40. She's got a diagnosis of breast cancer. Her mum died of breast cancer, also at a young age. And clearly she's going to have 2 key questions. And the first and kind of most pressing for her is, how are you going to best treat this cancer, clearly? And then the second question is, why has this happened to me? And those clues about the young age and the family history are kind of indicative that there might be an inherited cause for that cancer. So you probably know this already, but I think it's just really important to kind of pull out the difference between the acquired changes that cause cancer and the inherited predisposition factors that can cause cancer. And I always like to imagine this is basically the first cell that goes on to make a human, the fertilized egg, and within that cell is our 3 billion letter genetic code, which is our unique human instruction manual. That isn't the exact code, but what I've tried to highlight here is that within our human genome is actually a very small proportion that is vital for cancer risk, and of which, if we acquire genetic changes and variants that impact that important part, we significantly increase the chance of a cell developing into a cancer cell. So if we assume for a second this is not an inherited cancer, that cell will divide without any cancer changes, and every single time that cell divides, it will pick up an acquired change within it, because we copy 3 billion letters of our genetic code, and we always make a mistake every time we do that. But luckily, most of the time, it doesn't matter, because it hits the not very important part of the code. And then we start smoking and going out in UV light and living in London, and we also have mutagens that impact our DNA as well. And again, most of those will hit not very important parts, but the reason that cancer obviously is much more common the older we get is just the more times our cells divide and the more times we're exposed to environmental mutagens, eventually we will hit an important part of our genome with a genetic change that will drive that cell to have a growth advantage, to decouple from its normal mechanisms and to become a cancer cell. But every single one of these changes that have occurred throughout the lifetime of the individual will be present in that cancer cell. And it will acquire a lot more variants as well once it becomes genomically unstable and its DNA is damaged. And so we have these 2 different genetic codes inside a person with cancer. The one that they were born with, their germline or constitutional changes, and then this somatic or tumour or acquired changes. And we really need to consider both of these when we're talking about genetic changes that can drive cancer and the genetic testing that we will do in our cancer patients. It's not moving on. Oh, there we go. Okay, and the reason that we are having a massive expansion in genetic testing is that our ability to acquire, evaluate, and to detect genetic variation has just increased exponentially with the advent of genomic technologies to both look at the chromosomes and look for missing bits or added bits or rearranged bits, but particularly genome analysis, where we can now do whole genome sequencing in about 1 to 2 days for about £500. And so we're increasingly doing that, and we do that within our NHS healthcare service. So we choose And I'll talk to you about how we choose in a minute how much of our genetic information we want to look at, either in the cancer or in the inherited genome. Often for cancer, we might look at a single variant, like BRAF V600E, for example, in colorectal cancer or melanoma. Increasingly, we're doing gene panels where we're looking at a number of genes that we know could be specifically associated with driving that cancer to develop. We can look at all the genes, we can look at the whole genome. And this is, each dot represents the number of genetic changes that you will identify if you sequence that amount of genetic information in the germline. So this is around 5 million genetic changes, which is what we have in our germline. This can be even higher in cancer cells that have acquired all of those other changes along that pathway as well. So we can get a huge amount of variation if we look at the entire genome of a cancer and an individual. So coming back to that first point of how do we treat the cancer, actually the most information from that comes from looking at the acquired genome, because that is where we have the changes that have led that cell to become a cancer cell. And we can look for the driver variants, so what are the specific important cancer genes that were affected that drove that cell to become a cancer, and can that then lead us to a targeted therapy? We can count the number of different types of changes, mutations that have happened in that cell. And if we have huge amounts of genetic variants that have been acquired throughout a cancer, it's very different to normal cells. And so we can use immunotherapies to prime and attack those cancer cells specifically. And we can also look for mutational signatures, which are basically patterns of genetic changes driven by a specific mutagen. So cigarette smoke will leave an imprint in the cells because it mutates DNA in a specific way, and UV light will do that. And increasingly, we're getting to a stage where we can pull all of this out and we can stratify individuals into clinical trials or precision treatments. But the other thing that obviously I'm particularly interested in is why she's developed cancer. So a smaller proportion of individuals, but up to kind of 25 to 30% of individuals will have some genetic predisposition to cancer. Some of them won't, and if we think about environmental risk or just chance mutations through that process, actually that is still the most likely reason a person gets cancer, and why 1 in 2 of us will get cancer by the time we're kind of 80. But for the kind of 25 to 30% that have some degree of genetic risk, that can be polygenic risk, which we've just heard about, which is where we have multiple low-risk genetic factors, but they can add up together to get us closer to the threshold for developing a condition. And in general, they usually interact with other environmental or lifestyle or hormonal factors. But you can see that if you've been dealt this set of genetic variants, you're much closer to reaching the threshold for developing the condition than if you're dealt this set of genetic variants, where you need a lot more in your lifestyle or hormonal factors to get over the threshold. And then we also have monogenic factors, and those also vary in terms of risk, from intermediate, where again you'll need some interactions or some other things happening, to high-risk genes. So things like BRCA1 would be a very high-risk gene for ovarian cancer, for example, and might in itself just be enough to tip you over that edge. So one of the reasons that we're keen to pull out the difference between those who have these sporadic cancers where have no genetic factors and those that have some degree of inherited risk is really this drive as to thinking about, A, does that help us with the management, and B, does it enable us to put in other preventive factors. So in unaffected individuals or in individuals that have survived their primary cancer, so a person surviving a breast cancer that you've identified has an increased risk of developing ovarian cancer, for example. We can put in extra screening potentially, preventative medications, risk-reducing surgeries, and we can also offer testing potentially to other members of the family. So when we think about testing strategies and how we might identify individuals with enhanced genetic risk to then put those factors into place, you can either test the tumour genome. That's a very common thing to do on tumour DNA. That will contain all of the acquired variants, but it will also obviously contain all of the germline or constitutional variants as well, because there's a cell you were born with. It just has all of the cancer acquired variants too. And we can compare that against a different sample that's not from the cancer. So it's usually blood if we've got a solid tumour. If it's a blood cancer, we usually take a skin biopsy, and that contains only the germline variants. So you can see you can work out which is which if you have both of these and you subtract the germline from the tumour. But what we're tending to do in most settings is only sequence the tumour genome. And so we will, in doing so, also identify variants that potentially indicate they could also be inherited. So we need to have a pathway for deciding when we're suspicious enough that a variant might be constitutional inherited, and go on to confirm that and advise, even if we've just looked at the tumour up front. So if we see, for example, BRCA1 variant or BRCA2 variant in an ovarian cancer, or an MSH6 variant in an endometrial cancer, and we've only tested the tumour, that variant could be somatic or germline. The clinical benefit for that cancer patient is the same, because that is what has driven their cancer, and that's the driver variant that can require a precision strategy. And it's also increasingly clear that the clinical benefit of knowing this, if these are the driver mutations that have driven the cancer, is tumour agnostic. So even though there are things and cancers that are more traditionally associated with certain gene types, there is benefit in testing across all cancer types, because if you have been driven by these changes, you can still have the same treatment strategies. So examples of that would be BRCA1 and BRCA2, where if those are not working, they've driven that cancer because of failure of homologous recombination repair, we know that we can treat with PARP inhibitors. And in Lynch syndrome, with the Lynch syndrome genes, the loss of function of those genes has driven the cancer by causing a failure of mismatch repair, and this will give those tumours a very high tumour mutational burden, which will make them have more likely to have effective treatment with immunotherapies. So you will note that those genes, a lot of them, are also the inherited susceptibility genes as well. And particularly for tubo-ovarian cancers, BRCA and Lynch being the big hitters, there's also some intermediate penetrance genes, and Lynch particularly for endometrial cancer. So why is that important? Well, it's important because if those are going to be helpful for people being treated across all cancer types, and they're about to be tested across all cancer types, we're about to find a lot more of these genetic changes across all cancer types. So if we think about how do people access testing, there is in England a National Genomic Cancer Test Directory that in theory lays out the testing that we do on tumour DNA. There's a rare and inherited disease test directory that lays out the treatments we have on inherited or germline DNA. We're also doing large-scale whole genome sequencing across lots of pediatric rare diseases and things like that. These genes are considered very important. They can be reported back as incidental or additional findings. And I just came across from hearing Ranjit talk about his PROTECT-C study. They've just been doing the population Jewish BRCA study. There is going to be a huge expansion research studies that are looking for these genes across populations. So in terms of the cancer test directory that's being done in England, this specifies the tests that will be done on tumour DNA, and in some cases, who gets whole genome sequencing that's paired tumour and paired germline. It's freely available online. They are expanding that to meet government guidelines, the NHSE Cancer Unit, to open it up to all cancer patients and solid tumours to increase the number of genes that are being tested in that tumour setting. You will note that that includes BRCA1, BRCA2, all the Lynch genes, PALB2, RAD51C, RAD51D, all of which have implications for inherited gynecological cancers. There was an original plan for implementation that all genomic laboratory hubs should be upscaling to offering this across all cancer types, by the end of this year. That's probably going to be a little bit delayed, but this is probably coming for the reasons that I've articulated, that those will impact the management of the cancer for that individual. If you think about that, and this is the number of breast cancers taken from CRUK, the number of new cases per year, if we start doing this testing in all of these patients, you can see immediately how many additional tests are going to be done each year. This is just the bowel cancer rate as well, thinking about Lynch syndrome. And again, we're talking kind of 3,000, 4,000 patients from each of those categories each year potentially getting testing for these genes. So that's cancer, and that's what's going to happen in cancer. Massive uptick of sequencing of genes relevant for inherited gynecological cancers. We also already test individuals that we think have a over 10% chance of having a genetic change that increases the risk of gynecological cancers through the Rare and Inherited Disease Test Directory. I won't go into this in detail, but there's eligibility criteria. All high-grade epithelial ovarian cancers can get a genetic test for Lynch genes and for BRCA1, BRCA2 and the other intermediate penetrance genes. But these genes are also tested across a wide variety of other panels in those test directories, and they may well be reported. Now, this is important because NHS England and the Genomics Unit get direct funding for these tests, and the labs don't get paid for germline testing if it's not in this eligibility criteria. But there is always a push for increased access to germline testing. So, for example, the familial ovarian cancer guidelines significantly reduced the threshold for eligibility that is in the current test directory, but isn't currently implementable because we don't have the funding or resource to do that via our current pathways of referrals into clinical genetics. And then, as I've said, these genes are also being returned sometimes in the incidental finding setting, where it's much less clear whether they still have the same degree of risk as they are when they're found in cancer patients or in patients with a strong family history, and through research studies as well, both in cancer patients and unaffected patients, those with a family history and general population. And I've been more conservative than some of the figures that I've seen bandied for what the population frequency of these variants is. But, you know, probably there's about a 1 in 300 chance of detecting one of the Lynch genes and about a 1 in 400, somewhere between 1 in 200, 1 in 400 of picking up a BRCA gene. So this is a lot of people if you go out to the general population. And the government really want this. They want prediction, they want prevention. This whole, one of their 3 pillars, the change from sickness to prevention, and genomics is one of the 5 pillars that they have put in that. And this is, I am involved in this because I did want to be in the room thinking about this and the downstream impacts, but they have specifically name-checked a plan to sequence the genomes of 150,000 adults in the population to look at how genomics can be used in routine preventative care. That's predominantly driven by pharmacogenomics, but it will include these high-risk genes for gynecological cancers. So, with all of that in mind, there is going to be a significant increase in the detection of carriers with genes predisposing to gynecological malignancies who are unaffected but will want management and treatment. There is no funding in any of these research studies for the downstream management and care and risk-reducing management. The expectation is that the NHS picks that up. And even though I have concerns, particularly in the breast cancer space, prostate cancer space, all of those things about what the risk truly is in a population setting compared to a clinically ascertained setting because of modifying factors, almost all monogenic carriers will meet the thresholds for gynecological intervention, which is over 5% lifetime risk of developing ovarian cancer, for example. So, if you identify that a person has a higher risk of either tubo-ovarian or endometrial cancer, there isn't really any good evidence that surveillance has a reduction in mortality benefit, as we've just very nicely heard with prostate cancer. But that also is in guidelines that have been put out about considering surveillance in those that are at increased risk. As you will all know, there's an increasing drive to offer risk-reducing early salpingectomy with delayed oophorectomy, with very noble aim of getting women closer to the age of natural menopause before you remove the ovaries, if actually a lot of the risk is conferred by the fallopian tubes before the age of natural menopause. But that does require monitoring systems, recall systems, and 2 operations that need to be built into clinical services. And even if we're going to do one operation and go straight for BSO, which we might want to do if a woman is at age of natural menopause, we need to think about all of these things that is going to happen, and if we're doing it before then, what the impact of early surgical menopause might be. So, to summarise, there's going to be a huge increase in the number of avenues for identification of enhanced genetic risk, and that will be both monogenic, but also familial or multifactorial risk as well. It will come through all of those avenues, through upticks of cancer testing, through inherited testing, through research studies, through population screening. And somehow we in the NHS are going to be involved in the management then of that genetic risk. And in genetics, we'll be doing the cascade screening of relatives, but then you will need to be thinking about what are the issues for surveillance, the evidence base, the infrastructure, and for the surgical interventions. And I have to say, you know, gynecological cancer, ovarian cancer, it presents late. I think it is kind of the poster girl for prevention if you could get it right for those at high genetic risk. But clearly that is going to need a lot of thought about research, education and training and the workforce. So we are currently in a situation where there's inequitable access to assessment and management. The resource requirements do not exist in the system, as we were already hearing, for a significant uptick in demand for these services. We don't have good end-to-end pathways for good clinical care between primary care, secondary care and tertiary care services. We don't have good workforce planning. We have a bit of a disconnect between people putting out national guidelines that we can't then implement because we don't have any of the downstream resources and system change in frontline services to do so. And we need a huge amount of education and training to not do harm as we expand to population settings from our traditional paradigms of high-risk clinically ascertained families. So, huge challenges, but I think amazing opportunities as well. And so I'd be really interested in how we in the cancer genetics community can work with the people working in gynecological services. We need to educate and train, we need to collaborate, we need to get data, we need to model the impact, we need to develop pathways, we need to embed safe services. There's no point us finding all of these individuals if we can't do anything about their risk. That's worse than not finding them in the first place, I think. And we need to look at the cost and health economics and use that to then put together business cases for uptick and preventative surgery, services, and this is the political, you know, thing at the moment. This is what people are pushing for. So, in theory, if we could organise and do this well, it's something. It's a kind of shift that the government has said is one of their key shifts over the next 10 years. And I think really importantly, we need to solve this gap between doing research study and saying, well, this is a benefit, but just not being able to implement it because there is not any funding. We haven't engaged commissioners. We haven't thought of an exit plan. So I will finish there and just say that there is this large-scale genomic testing coming, and I do really believe the clinical benefit of this is huge, and particularly for something like ovarian cancer, where outcomes are traditionally poor. If we could prevent that with a low-risk operation with limited harms, but we really need to embed resourced end-to-end pathways to reduce and manage the risk. Thank you.
Thank you for yet another really fabulous talk this morning, and it's been a great session. I guess my question, because Andy's about to ask one, because he's cancer lead of his trust. Is, you know, we're already facing huge backlog in gynecological surgery for Where are we going to find the theatre? You know, and it's always the first. You know, it's the frustration. It's always the first list that goes down before elective orthopaedics, before all sorts of other stuff. It's always the gynae list that goes down. How are we going to do this?
So I think my personal feeling is we have to present services outside of what we're doing at the moment. I just don't think it is feasible for us to be able to implement this with the current models of service delivery for those reasons. And I think there is a big political will around prevention as a sort of separate thing. So I don't know, and you know, this sort of naive, optimistic kind of thing of doing it, but I think we need to do some modelling, and we need to kind of go with an innovative business model that takes it out of frontline NHS and kind of has it as a sort of preventative service. Now, that doesn't solve the workforce issues at all, but I think we can't kind of just try and do this as business as usual. It's not business as usual, and you know, if what they're truly saying is there's a difference between sickness and prevention and we need to get to this point, then we almost have to separate those two and say we need to run a prevention service and it needs to be fully resourced and stopped, and we're not shoving all of these unaffected women to have risk-reducing surgeries in with the people that are sick or have disease, you know. So I think and they can't really argue with that if they're putting it all over 10-year plans and saying that this is what we need to be doing. So I guess I don't know, and it's clearly going to be more challenging than that. But what I would say is I think we need to innovate and push for different models of service delivery that sort of play to this as a different type of service in the NHS.
I was going to ask a question on private testing, but that's been trumped now because we're now testing everyone all over the shop. So I've got two questions. The first question is, I can't get BRCA tests turned around on cancer patients in a targeted time. How on earth are we going to roll this out for everyone? And the second question is, my challenge in my clinic now is not young patients and surgical menopause issues. It is people which have had 2 MIs who've been diagnosed at the age of 64 who've came through from breast mainstreaming. And the risk-benefit for those patients is a much more tricky calculation to make, and actually probably has a lot more sequelae and issues coming through afterwards, let alone sort of, you know, post-total colectomy patients who are now diagnosed with Lynch. You know, this is not a 20-minute operation. This is now a 3 to 4 hour operation and an ILIAS afterwards, and the rest of it. How are we going to manage that?
Okay, so two things. So laboratory and testing capacity, first of all. So the genomic laboratory hubs are under the control of the genomics unit. They have just been told that they are having a kind of funding squeeze as well. They've been told they need to reduce demand. They've been told that they need to, you know, start rejecting demand management, these sorts of things. So again, I don't think that that's going to be easily solved. And we've got a shortage of clinical scientists. So I think there has to be money to do the testing, otherwise you can't do it. I do think there are different ways, again, of delivering it. And they are moving to kind of larger scale resequencing. You know, there's things like BRCA Direct that have been delivered, which is, you know, about getting saliva kits to patients, doing it through external laboratories, returning results in different ways. So I think, again, probably a bit boring, but we can't just do it from existing paradigms, is what I would say. And we can't do it without funding and resources. So I think that's right. It's a massive problem. The second thing about is risk-benefit of intervention as we're moving to different settings, different ages, populations, those sorts of things. And again, I think it just needs a total rethink of how we're delivering this if we're doing it in a population setting, and also really good data on the health economic benefits, the harms across those different age ranges. The problem is it takes time and resource and people in policy to actually sit and model this properly. I mean, you've got people that are doing that, you know, like Ranjit's done a lot of health economic modelling, but I think we need to sort of get our head around the fact that we need data, and we need to actually start looking at models of service delivery and the costs and the harms and the benefits as we're moving away from old paradigms of delivery. So I think we almost need to sort of break the system a little bit and go, this can't just be added on and integrated. We have to just stop and say, if this is your vision, if this is what you want to do, we need to look at it and say, okay, well, now we need to change it, and these people will be eligible, and if we find this and this. And so my personal belief is we need to go from a gene-specific model to a risk-specific model, which is personalised, not just with the genetic data, but with your age, with your comorbidities, with your lifestyle, your medical information, your polygenic risk, your monogenic risk, and how old you are, like what is your 5-year risk, what is your 10-year risk, and we need to start breaking it down instead of going, okay, you've got BRCA2, don't care how old you are, you're 70, refer for a chat about risk-reducing mastectomy. That doesn't work anymore. So I think we need basically a paradigm shift to risk in an integrated data model, taking into account all of those factors. But it's unbelievably hard to do because people want to go, okay, you've got this, we do this. But that's the shift I think we need to prevent harm.
Thank you.
I think we're all stunned here, Katie.
Yeah.
One more question.
I'd like to say this is what I'd like to see, the chance of any of it. Yeah.
Hi, thank you so much for your talk. My name's Aisha. I work at Derby with Ms. Phillips. I just had a quick question about how you handle all of this genomic data for individual patients, because obviously you're going to have quite sensitive data, which in an increasingly private sector with medical insurance, how are you going to manage that sensitive data to prevent that leakage being used by unscrupulous companies to take advantage of these people?
Yeah. So data privacy is a massive concern. And if I talk to people in clinic, the main thing they're worried about, even with a predictive test for something in their family, is an insurance company going to get hold of this data and discriminate against me? And I'm not sure there are easy answers to some of those questions. I think there needs to be a public dialogue, and I think people like Genomics England have been having this kind of public dialogue about having kind of repositories of whole genome sequence information, and the National Genomic Research Library, who has access to that data. That's very informed by patients and the public. I think that needs to continue. Clearly, cybersecurity, things like just not hacking into a database and stealing people's genomics data is really important. I think there needs to be a huge engagement exercise around trust, and we need to also build the kind of policy around what is a reasonable use of genomic data and what is not a reasonable use of genomic data. But things shift, don't they? The political situation in America has completely shifted in terms of a lot of genetic variants were in public repositories that were run by federal government. There's been a huge funding cut. All of these concerns are very influenced by politics, and I don't think we can promise to people that their data, won't be changed as there are different political situations. So, I think we have to be very cautious. I don't have an answer, but I think you have to be mindful of all of those things. You have to put in the most robust measures and have a very clear idea of how you want to use data for healthcare benefit. Because I think one of the major problems with genomics at the moment is it's very biased to people of Northern European ancestry. Now, that doesn't allow everyone to benefit in the same way from healthcare advances that are driven by genomics, but equally there are huge sensitivities in driving an uptick of generation of genomic data in underserved communities of different genetic ancestries. So I think it's an iterative process, and it's building trust, and it's having very clear ideas and understanding what the concerns are, but also putting measures in place to try and protect things as much as you can.
Wonderful. Thank you so very, very much. I'd like to thank you, Katie. I'd like to thank all our speakers today. It's been a really fantastic, a really wonderful session. Anna, thank you for your really clear description of all the data and the rationale to centralise sarcoma services. Gerald, you've given us a fascinating insight into AI and how that can be used in breast screening and potentially in gynae screening as well. Hashim, thank you for taking us through all the screening in prostate cancer, the political backdrop, and we'll be fascinated to see whether Transform goes ahead or not. Hopefully it will. And Katie, you've made the huge complexities in genetic screening really simple, really straightforward. But I think open more questions than you've answered. But it's been wonderful. Thank you all very much indeed.
Good morning, everyone. Welcome to the Kaleidoscope session 2. Myself, Ketan Gajja, gynae oncologist and BGCS officer, we are chairing session, and I got my colleague Michael Sidris with us. We got quite an exciting program over the next hour and a half, so I'm looking forward to it. So as you, and just to say that our first speaker, Prof. Jayant Vaidya, is not well. I didn't know COVID did exist, but apparently he tested positive for it, so he's not here. But we are lucky enough that our second speaker, Dr. Sarah Glynn, is able to cover the topic. Thank you, Sarah, for stepping in. So without much delay, I would like to invite Sarah Glynn to give us a talk on menopause care and HRT after breast cancer. Sarah has contributed to the HRT guidance in association with British Menopause Society. She's well published and she has special interest in HRT in breast cancer. Sarah, off to you.
Thank you. Can everybody hear me okay? So yes, Professor Vaidya and I were supposed to be presenting this lecture together, so it's very unfortunate that he's at home with COVID this week. So I'm afraid you've just got me, but I'm going to have a good go at presenting all the slides instead of just mine. And the reason we were invited to do this talk is because we've recently been working on a paper that aims to define the role of HRT after breast cancer. It's taken 3 years to write, and it's just been accepted for publication. We hope it's going to be available online in Menopause, which is the journal of the Menopause Society, previously known as the North American Menopause Society. It should be available hopefully from about August. So that's essentially what I'm talking about today. And as I'm sure you're all aware, HRT is currently contraindicated after breast cancer. This is taken from the NICE Breast Cancer Guideline, and it states that women should only be offered HRT if they have severe menopausal symptoms in exceptional circumstances after discussing the risk. But unfortunately, there isn't much guidance out there around how to talk about risks after breast cancer in women who want to take HRT. And it's very important that if we're seeing breast cancer patients in our clinics, that we not only recognise the risks, that we quantify or estimate the risks as far as we are able to based on currently available evidence, and that we also consider the benefits alongside the risks so that women can make informed treatment choices. And the reason that HRT is contraindicated after breast cancer, there are three main reasons. So the first is that, as I'm sure you're aware, in the Women's Health Initiative trial, there was an increased incidence of primary breast cancer in women who use combined HRT compared with those who use placebo. Secondly, we've now got lots and lots of high-quality data from large randomized controlled trials and meta-analyses showing that reducing estrogen exposure improves survival after breast cancer. Intuitively, it therefore seems likely that if women take HRT, this is likely to have a harmful effect. And finally, we have some very limited data from studies that have looked at women who've taken HRT after breast cancer, looking at breast cancer outcomes and the increase in risk of relapse by use of HRT. And we're going to talk about each of these individually. So very briefly, because as I say, I'm sure you're familiar with this study, the Women's Health Initiative trial was a huge study, first published in 2002, in which 16,608 women with a womb were randomized to receive combined HRT. They were given conjugated equine estrogen and a synthetic progestin for 5.6 years, or placebo, and hysterectomized women who did not have a uterus were randomized to receive conjugated equine estrogen alone. And this is the long-term follow-up data. If you focus on, I think, hopefully you can see it's a yellow line. The paler line is the women who were in the combined HRT arm. The dotted line is the placebo group, so that shows the breast cancer incidence over 15, 20 years in the placebo group. And you can see that the solid paler line, yellow line, shows there was an increase in risk of breast cancer in women who took combined HRT over this time. Conversely, in the women who took estrogen only, conjugated equine estrogen only HRT, the breast cancer incidence in the placebo group, the dotted line, the dotted blue line, is very similar to that in the other arm of the trial, not surprisingly, but the incidence of breast cancer after 15, 20 years of follow-up was lower in women who took estrogen on its own. And this slide just summarises the graph that you've been previously looking at, and it shows that the increase in risk was small in women using combined HRT. It was a 0.9% absolute increase in risk, and the decrease in risk in the women who used estrogen-only HRT was almost exactly the same, minus 0.9%. In women who were randomised to receive estrogen-only HRT, there was also a significant reduction in breast cancer mortality after 40 years. There was a trend towards an increase in mortality in women using combined HRT, but it never reached statistical significance because presumably the increase in risk was very small. And then, as I've said, the main reason I think against using HRT after breast cancer is because we know that estrogen receptor positive breast cancer thrives in an estrogen-rich environment, and depriving women of estrogen or blocking the estrogen receptor in breast tissue has a beneficial effect, reduces the risk of relapse and reduces the risk of dying after breast cancer. In high-income countries such as the United Kingdom, breast cancer mortality has roughly halved over the last 40 years, and that's mainly due to the introduction of tamoxifen in the 1980s, possibly chemotherapy as well, but more women in the UK are given tamoxifen than chemotherapy, so we think tamoxifen's likely had the bigger effect. But breast cancer mortality since the introduction of tamoxifen has gone from roughly 30 per 100,000 women down to 15. This just quantifies that for you so you have a better idea of the absolute benefits. These are the absolute benefits. And breast cancer mortality at 15 years is around 33% in women who are randomised to a placebo, but it's 24% in women who are treated with tamoxifen and 20% roughly in women who receive anastrozole, which is an aromatase inhibitor. Again, this slide just summarises the graph so that you've got a better handle on the numbers. Ovarian function suppression, a 3% absolute risk reduction, tamoxifen, a 9% absolute risk reduction, and aromatase inhibitors are approximately a 13%. They are the most efficacious treatment. And then really, there have only been a handful of trials that have looked at clinical outcomes after breast cancer in women who've taken HRT. The two most well known of these would be these two: Habits, hormone replacement therapy after breast cancer, is it safe, and the Stockholm trial. And these were two contemporaneous randomized clinical trials that occurred in Sweden. They started in the 1990s. And they were both quite small, as you can see, only about 350 women in each trial, and they were both quite short because at 2.6 years, an increased risk of relapse started to emerge in the Habits trial. And at that time, the Data Safety and Monitoring Committee pulled data from both studies and calculated a hazard ratio of 1.8, an increased risk of breast cancer event, be that local relapse, distant relapse, or contralateral breast cancer. And because of this, both trials were discontinued prematurely, even though at that time, no increased risk of relapse or breast cancer events was observed in the Stockholm study after 4.1 years. And it's a shame because that's actually all the data we've currently got concerning women who've taken HRT after breast cancer. There are lots of problems with these studies, lots of limitations. So firstly, both studies enrolled women with estrogen receptor negative breast cancer as well as estrogen receptor positive breast cancer. And clearly a risk by use of MHT is likely to be different depending on your hormone receptor status. Women mainly received combined HRT regimens and they all received synthetic hormones. So in Habits, the progestogen was norethisterone, and in the Stockholm study, it was medroxyprogesterone acetate. The Stockholm study was specifically designed to minimise progestin exposure because at that time, the results of the Women's Health Initiative study were becoming available, and we were becoming aware that the increase in risk of breast cancer appeared to be linked to the synthetic progestin rather than estrogen, which has breast protective effects in the estrogen-only arm of the Women's Health Initiative. So in the Stockholm study, 95% of the women received quite a low dose progestin, MPA, but in the Habits, more than half of women received a normal dose MPA. As I've already said, the duration of the studies was very short, and because both trials were discontinued prematurely, they were underpowered. So in Habits, only about 300 of 1,300 planned participants had been recruited when the trial was discontinued. So both studies, including Habits, are underpowered to detect a difference between the two groups. So this is the best data we've got, but it's got lots of problems, lots of limitations, lots of factors that may account for the discrepant findings between the two trials. Nevertheless, so Professor Vaidya and I have made this infographic which accompanies the paper when it's published. And what we've done is we've taken the data from Habits and Stockholm, because it's the best we've got, and we've tried to present this to help doctors counsel women about risks if they choose to take HRT after breast cancer, because there is undoubtedly a risk, but the degree of risk will vary from woman to woman, and what she decides to do with that information is also likely to vary considerably, depending on her symptoms, her quality of life, and so forth. So in the left-hand column, this is women without a history of breast cancer. It's WHI data, and it just demonstrates that in women who use combined HRT, synthetic hormones, there are 4 additional cases of breast cancer per 1,000 women who use HRT over 5 years, whereas in women who are using estrogen-only HRT, there are 4 fewer cases. So small absolute increases and decreases in risk. If we look at the coloured infographics, these are women who have a history of breast cancer. So the middle column, this is the numbers taken directly from Habits and Stockholm. At the top figure shows relapse rates in women who have not received HRT. So over 5 years from diagnosis, you would expect 205 out of 1,000 women to relapse, and we've stratified that into type of relapse: local, distant, contralateral breast cancer. Now, if all those 1,000 women used HRT, this is quite a medium risk breast cancer. And if all those women used HRT, then the number of relapses would increase from 205 to 324. That's a 12% absolute increase in risk of relapse. So the first thing you see is that the risks are clearly very different after breast cancer compared with women without a history of breast cancer. Interestingly, if you look at the lower figure and look at the breakdown of type of relapse, most of that increase in relapse actually is in an increase in risk of local relapse and contralateral breast cancer, which clearly are undesirable. Nobody wants to have a relapse, but they are usually treatable. The effect on distant relapse is actually quite minimal. HRT doesn't seem to adversely affect the risk of distant relapse too much, which is quite reassuring, because distant relapse is not treatable. And then finally, we've just got the figure on the right-hand side, which essentially shows the same thing, but this is women with low-risk breast cancer. So these are the type of women that I tend to see in my menopause clinic. You know, these are women who've had a low-risk, low-grade, localized tumour, small tumours. They've come to me, their background risk of relapse is very low, and they want to know how much potentially it might be increased by use of HRT. And as with the higher risk group, there will be an increase in risk, but the numbers are much smaller. Overall, it's a 3% absolute increase in risk of relapse, mainly, as I've said already, in contralateral breast cancer and local relapse, which is undesirable but treatable. The absolute increase in risk of distant relapse is 0.3%. It's there, but it's small. So having established risk and tried to quantify risk, we've then got to talk about the benefits of HRT for women, all women after breast cancer. HRT is licensed to do 2 things. Firstly, and mainly, it's licensed to treat menopausal symptoms and improve quality of life. And in women without a history of breast cancer, we know that 85 to 90% of women will experience menopausal symptoms, median duration roughly 7 years, but 40% of women will experience menopausal symptoms for more than 14 years. And around 1 in 4 women will report severe or debilitating menopausal symptoms that negatively impact their quality of life, their ability to work and function. And this is data taken again from the Women's Health Initiative study, looking at RCT data, and both combined HRT and estrogen-only HRT significantly reduced vasomotor symptoms compared with placebo. The benefit was greater in women using combined HRT, which is likely because progestogens also have beneficial effects on vasomotor symptoms. It's not just estrogen. And in the Women's Health Initiative study, there were also significant improvements in sleep, joint pain, quality of life, etc. HRT is also licensed in cancer-free women to reduce the risk of osteoporosis. It reduces the risk of osteoporotic fracture by 30 to 40%, depending on fracture site. It's not licensed to do this, but we've got high-quality data from randomized clinical trials showing that HRT reduces the risk of diabetes by 30%. If it's initiated within 10 years of menopause, it reduces coronary heart disease by up to 50%, and it reduces all-cause mortality by around 30%. Now, you will notice that the absolute benefits in women in their 50s are small, and that's because, fortunately, women in their 50s don't tend to die, hopefully, from cardiovascular disease, etc. So if they take HRT for longer, then those benefits are likely to accrue and accumulate over time. But women in their 50s, the absolute benefits in terms of long-term health and comorbidities are small. So basically, in women without a history of breast cancer, the menopause guidelines concur that the benefits will outweigh the risks in most women if they have menopausal symptoms. But of course, this needs to be tailored to the individual. There are other things that we can do for menopausal symptoms. In women with a history of breast cancer, the benefits are the same, but the risks are greater. And therefore, HRT is currently contraindicated in women with any history of breast cancer, whether it's DCIS, ER negative, ER positive. Any history of breast cancer currently is a contraindication for HRT. And that presents a problem because lots of the treatments that we use for breast cancer, not surprisingly, they are suppressing estrogen or blocking estrogen receptors, and therefore they have lots of side effects that cause menopausal symptoms. So vasomotor symptoms, joint pains, vaginal dryness, UTIs, metabolic dysregulation, loss of bone density, etc. And in fact, this is an observational study comparing women with versus without breast cancer. And we know that the prevalence of menopausal symptoms is higher in women who've had a history of breast cancer compared with those that haven't. These are women that were previously treated for breast cancer. It's likely that if they had surveyed women who were currently receiving treatment for breast cancer, the prevalence, the symptom prevalence would have been higher and the difference would have been greater, but we don't have that data. Also, we know that the severity of menopausal symptoms, this is the same study, the severity is greater in women who've got a history of breast cancer as well, but I haven't presented that data here. And at the moment, because HRT is contraindicated, we're therefore limited to giving women non-hormonal treatments first line. And these can be effective. So vasomotor symptoms, we commonly use things like antidepressants. Clonidine is the only treatment actually licensed to treat vasomotor symptoms. The others are all off-license. We've got the new neurokinin receptor antagonists, such as fezolinetant, that are coming out. For women with low to maybe medium severity genitourinary symptoms, we can use vaginal moisturizers and lubricants. The problem with non-hormone treatments is that they are less effective. So in one study, about 17% of women found their non-hormone treatment to be effective. The other 83% reported that it was only somewhat effective or ineffective. Secondly, they are symptom-specific. They're helpful if women are suffering with vasomotor symptoms or mood symptoms, but they won't help women who've got joint pain, vaginal dryness that hasn't responded to vaginal moisturizers, urinary symptoms, palpitations, sleep problems. In fact, side effects of these non-hormonal treatments, like any drug, they can cause side effects, and many of the side effects overlap with menopausal symptoms. So some of these treatments may actually be exacerbating some of the other symptoms that women are experiencing, such as sexual dysfunction, fatigue, palpitations, etc. And these non-hormone treatments are also associated with an increased risk of long-term harm. It's small, but SSRIs are associated with an increased risk of fracture, not what you want in someone who is using anti-estrogen therapy. Anticholinergics are associated with cognitive decline, withdrawal, dependency in people using pregabalin, gabapentin, etc. And rarely, fezolinetant is associated with liver toxicity, so we now have to monitor women's LFTs if they're taking it. It's not been approved by NICE in the UK, and possibly an increased risk of cancer in women taking fezolinetant. This is based on the results. The reference there is Dufil et al., the 2023. It was a small meta-analysis that was published in The Lancet, showed that actually there was an increased risk of cancer in women who were taking fezolinetant. Now, there's not much data about this. There's currently a trial underway, the Highlight trial, looking at fezolinetant in women who've had breast cancer. But at the moment, we don't have any data about women who've had a history of breast cancer, whether fezolinetant is safe or not. So we're waiting for that data. And at the moment, I wouldn't prescribe fezolinetant personally until the results of that study have been published. So not surprisingly, given that these treatments don't work very well and they've got lots of side effects, if they do work, that's great, but they often don't. And 30 to 70% of women are dissatisfied with the quality of their menopause care, or they feel unsupported in cross-sectional surveys. 60 to 96% of women want more support to manage their menopausal symptoms. And in these 4 studies here, up to 58% of women would consider HRT to manage menopausal symptoms despite the risks. Now, it's interesting. I was attending a couple of talks earlier. We were talking about prostate cancer, and the professor was saying that men would trade off a survival benefit associated with their treatment in exchange for maintained sexual function, not having incontinence, urinary incontinence, etc. And I think this is the key. There's a balance between quantity of life, which is essentially what we're trying to achieve with tamoxifen, AIs, etc., and quality of life. And what we're trying to do with this paper, and we're trying to move the conversation on, is to think about both quality and quantity of life and what that means for the individual in your clinic. Obviously, in large cross-sectional surveys, there's a potential for selection bias because women who have severe menopausal symptoms or are not satisfied with their menopause care are more likely to respond to these surveys. But in these studies that I've quoted, there are about 4,000 women. So whatever the true prevalence is, there is definitely a problem with women who are not happy with their menopause care that they're currently receiving after breast cancer. These are quotes taken from a paper that we had published in Menopause earlier in the year. We did a big survey and we thematically analysed free text comments left by about 220 of the women. And I've just included them because these are very typical of the types of things that I hear in my clinic. It's women feeling unheard, shut down, not listened to, not able to exercise the treatment that they think they need. And there just appears to be quite a disconnect between what women think they want and need and what doctors think women want and need. And it's just about listening to women and not shutting them down and letting them have a say and trying to help them. I've met several patients who've almost had to leave their job. I met one patient actually who she'd had breast cancer when she was in her 30s. She'd had her treatment finished. Her periods had come back. She'd been having periods for 10 to 15 years. So she'd had lots of estrogen. Then she'd hit menopause and was really struggling with vasomotor symptoms, menopausal symptoms, to the point where she couldn't work well and was worried she was going to lose her job. And if she lost her job, she was single, she would have lost her flat because she couldn't have afforded to pay her mortgage. If she'd lost her flat, she would have had to move in with her parents again. She would have lost her independence, all because no one would give her any HRT after she'd had her own hormones for 15 years. So how do we talk to women? Clearly, not all breast cancer is the same, and we've covered all of this in the paper that's coming out. Clearly, we don't have time to go into all of this morning, but clearly the risk of relapse by use of HRT is going to vary considerably depending on the type of breast cancer you've had. And the risk of relapse after DCIS, which is not cancer, is non-existent really with HRT, although there may be an increase in risk of second breast cancer because these are women who have a higher baseline risk, probably depending on the type of HRT that you use. Equally, after estrogen receptor negative breast cancer, if you don't have estrogen receptors, HRT cannot increase your risk of relapse. Again, you've got to think about the risk of having a relapse that's estrogen receptor positive or a second breast cancer. We've talked about this in the paper, but the risk is likely to be low. And when it comes to estrogen receptor positive breast cancer, the increase in risk by use of HRT will vary considerably depending on the background risk, which of course depends on things like the grade, the stage, the size of the cancer, etc. The treatment received, whether they're actively receiving treatment, that's going to influence your treatment decisions, whether they've completed treatment, the time since diagnosis, all of these factors will influence risk after breast cancer. Not all HRT is the same. We've got lots of very good observational studies now suggesting that vaginal estrogen is very safe after breast cancer. It's very, very low dose, and it's not absorbed after the first few weeks. It's only a very transient, low-level absorption for the first few weeks of taking it, and allowing for the fact that we don't have any RCT data yet to confirm safety. Most people are very happy now that vaginal estrogen is safe. Synthetic versus body-identical hormones and type of hormones we're just going to talk about very briefly. So most of you will be aware, as I said earlier, in the Women's Health Initiative study in which women received medroxyprogesterone acetate, a synthetic progestin, there was a small increase in breast cancer risk. But progestins, synthetic progestins, and body-identical progesterone have very different effects on breast tissue. This data is taken from the E3N cohort study, which was a prospective cohort study done in France, about 80,000 women. They use a lot of micronized progesterone in France, and I'm sure lots of you have seen this before. But in line with the RCT data, on the right-hand side, women who received estrogen with a synthetic progestin, there was increase in risk of developing breast cancer, but that was not seen in women who were treated with estrogen and body-identical progesterone, the pink bar in the middle. Similarly, there was no significant increase in breast cancer risk in women who were treated with estrogen and dydrogesterone, which is a body-similar progestogen. So it depends on progestogen type. And as I've said, that's because progestins and progesterone have very different effects on breast tissue. This is a very small RCT, just 77 cancer-free postmenopausal women randomized to receive either synthetic hormones or body-identical hormones. And in the women that received the synthetic hormones, there was a significant increase in breast cellular proliferation. Ki-67 is a marker of cellular proliferation, and a significant increase in breast density that was not seen in women who were treated with body-identical hormones. And further, when they did gene analysis, they showed that the expression of about 2,500 genes was affected in women who were treated with synthetic hormones, compared with only 600 genes in women who received body-identical hormones. They have very different effects on breast tissue. We don't have much clinical data at all concerning progesterone after breast cancer. We do know that the progesterone receptor is a positive prognostic marker in women with estrogen receptor positive breast cancer, and its loss correlates with treatment resistance and a worse prognosis. And in preclinical studies, progesterone is a tumor suppressor in estrogen receptor positive cells. So this is a very interesting study that was published in Nature in 2015, and it was a mouse model. They took MCF7 cells, which are breast cancer cells, and they grafted them onto mice, and then they treated the mice either with estrogen on its own, or with estrogen and progesterone, or with estrogen and tamoxifen, or with all three. And as you can see on the y-axis, we've got the tumour volume, and the mice that received estrogen on its own, the tumour volume increased the most. The addition of progesterone appeared to abrogate the effect of estradiol on breast tumour volume, so the increase in size was less. Not surprisingly, the mice that were given tamoxifen had a better effect, but the biggest effect, the biggest reduction in tumour volume was seen in the mice that received all three, the estrogen and the progesterone and the tamoxifen, suggesting that potentially tamoxifen and progesterone might have additive effects. And finally, this is the WinPro trial. Preliminary results have just been presented at the ASCO conference in the States. This is a window of opportunity trial. So these are women with low-risk estrogen receptor positive, progesterone receptor positive breast cancer, and they were randomized to receive either letrozole on its own, letrozole with progesterone, or tamoxifen with progesterone for 2 weeks prior to breast cancer surgery. Then they had their surgery, and they looked at the histology. And you can see that in women who were treated with letrozole alone, the aromatase inhibitor suppressed Ki-67, so it suppressed cellular proliferation by about 88%. And similarly, in the women that received an AI with concurrent progesterone, suppression was about 89%. So in other words, the addition of progesterone to the AI did not appear to compromise the efficacy of the AI. Suppression was slightly less in women treated with tamoxifen, which is to be expected because tamoxifen has lower efficacy compared with an AI. But they also showed that the hot flush frequency was significantly reduced in women who were treated with an AI and concurrent progesterone, almost halved. So this suggests that possibly, obviously we don't have enough data to recommend it yet, but it suggests that possibly progesterone might be a safe therapeutic option, maybe, for women who've got estrogen receptor positive breast cancer and are suffering from vasomotor symptoms. It's interesting. So not only are all breast cancers different, HRT is different, but also, of course, not all women are the same. And women's interest in having HRT, am I okay time-wise? Women's interest in having HRT will depend on their menopausal symptom burden, their quality of life, other comorbidities, how they feel about their risk of relapse, where their priorities lie, their treatment goals, life goals, etc. Everybody is different. A 1% or a 5% increase in risk to one woman will not necessarily mean the same thing as it would to another woman. So I was going to do a case study, but I'm just wondering if I've got time. I'm actually going to scoot through the case study, if that's okay, and just come to the end slides. This was someone with a low-risk breast cancer who essentially didn't initially want HRT, and then she decided to have it, quantified the risk, and she now feels great. This slide is probably quite important. It's how we sort of think about quantification of risk for women considering HRT after breast cancer. And we can use the predict tool, which I scooted past just then, and the infographic that I've shown you already. And assessment of the background risk can be used to estimate the increase in risk of relapse by use of HRT. If the background risk is low, then presumably, if the AET, the adjuvant endocrine treatment benefit is small, then the risk by use of HRT is also likely to be small, assuming that there is a proportional relationship. If women have high-risk disease and they have a higher risk of relapse and they stand to gain more from taking tamoxifen or an aromatase inhibitor, then presumably the risk if they choose to take HRT will be higher. And we can use PREDICT, we can use the infographic to try and quantify this for women and show them where their level of risk lies. But many women, or some women, we don't know how many overall, may choose to accept a small increase in risk of relapse in exchange for a better quality of life, just as many men might accept a trade-off between survival benefit and sexual function, urinary function, etc. It depends on the individual. It's not just us that are starting to think that. It was interesting attending the talks earlier because it's obviously a conversation that's opening up in other branches of oncology as well. People are beginning to talk about it more after breast cancer. These are a couple of other papers that are talking about actually tailoring advice to the individual, recognizing risk, estimating risk, and considering the benefits of HRT and letting women decide for themselves what they want to do. A blanket no is very unhelpful. These are other things that we've talked about in the paper. So, as I said, we've also talked about the different risks after different types of breast cancer. We've looked at testosterone, the vaginal hormone data. HRT is an option in women who are currently receiving tamoxifen. Testosterone potentially might be an option in women who are currently receiving aromatase inhibitors. And then we've briefly looked at BRCA-positive Immunocore and Duaviv. And finally, we are proposing that given the paucity of data in this field, we are proposing that we should set up a study, we've called it the MENO ABC trial, because the older trials were small, they were heterogeneous, they were stopped early, we don't really have much information, and they didn't consider the benefits of HRT and women's choice, the importance of shared decision-making, etc. And the idea is that when there's a genuine clinical equipoise and someone genuinely doesn't know if they want HRT or not, we might be able to randomize them to either HRT and no HRT or HRT and the next second-line treatment. And if women, because many women are already taking HRT after breast cancer, and if they want to have HRT and they've decided that the benefits outweigh the risks, then we should be prospectively following them for both breast cancer outcomes and non-breast cancer outcomes, so that in 10 years' time we can hopefully quantify the risks and benefits much better for women, and hopefully this will support shared decision-making for hundreds of thousands of women worldwide. And that's all the references.
Thank you, Sarah. Fascinating talk, and looking forward to the publication. If there are any questions, we'll take one or two questions. Come there, please. Just here.
Thank you very much for your talk. It was excellent.
Thank you.
In terms of topical estrogen therapy for women at high risk of recurrence, would you recommend starting at the standard dose of estrogen cream or Vagifem, or a reduced dose?
I would just go with standard. So the data, again, we've summarised this data in the paper, but there is some transient low-level absorption. Levels remain fully within the postmenopausal range when women start using low-dose vaginal estrogen. But within a few weeks, blood levels have normalised, and as the sort of vaginal epithelium plumps up, absorption falls, and actually it can't be a risk. I think Professor Vallejo suggested that if people are still very anxious about it, for example, if patients are on an aromatase inhibitor, you could even consider switching them to a tamoxifen, which doesn't have quite so severe side effects, use vaginal estrogen, and then when their vaginal epithelium is better and healthier, they could then be switched back to the AI if you're really anxious about it. But, you know, a Vagifem pessary is 10 micrograms, and the weekly dose in women who are using a standard dose is 1/350th of a 1 milligram oral HRT tablet. It's tiny, and it just doesn't impact blood levels. And if it doesn't get absorbed, how can it possibly affect your breast cancer risk? All the observational studies are saying that there's no increase in risk of relapse after, you know, if you're in women who use vaginal estrogen. Yes, we don't have a randomized clinical trial, but honestly, I feel like resources could probably be better allocated knowing that it's not absorbed and it's
I have a question. So it's clear from your work that we need to just not have a blanket no to HRT in women with breast cancer.
Yeah.
How do we influence change in the policy or guideline? Because unless we do that, we can't move forward. So hopefully your publication would help, but engaging with NICE or people who publish the
Absolutely,
guideline
yeah.
we need to engage.
And it's really interesting because NICE have also produced a shared decision-making guideline, which actually sort of contradicts the breast cancer guideline. You know, you can't have one guideline saying never give it, another guideline saying, well, why don't you talk to the patient, give her the risk, give her the benefits, and let her decide for herself. You know, the importance of informed choice. And I think it will shift, and I think it's totally understandable that up until now, people have been very reluctant to give HRT. You know, but it's just, as I said, it's not just breast cancer. I think in oncology generally, there's an increased awareness of the importance of quality of life as well as ideally both, but quality of life is also very important. And yeah, absolutely. Hopefully, as this paper is published and people start talking about it more, it would be really nice to see the guidelines change to informed choice rather than never.
And finally, we are having a research subgroup within BGCS, so we'll be very much interested to see your research trial and how BGCS can help to collaborate.
Absolutely, that would be great. Thank you.
Thank you. Thank you very much. So that brings the first lecture to end.
I think we're gonna slightly shift now the topic of the lecture. So we all heard the fantastic news of a baby being born after uterine transplantation. So the next topic, the speakers don't really need an introduction, but I'll do a brief one. So we're going to chat about the uterine transplantation and applicability in cancer care. First speaker will be Professor Richard Smith, who is a consultant gynecological surgeon and professor at Imperial College London. He's the chairman of womb transplant in the UK charity. And then following that, Miss Isabel Quiroga, who is a consultant transplant surgeon, kidney and pancreatic transplantation in Oxford. So both of them will give us the valuable insights on the uterine transplantation topic. Thank you.
Thank you very much, Mr. Chairman. Ladies and gentlemen, a pleasure to be here. What we're going to do in the next half hour is Isabel and I will tell you a story which has spanned over 25 years. And it's a story of two teams which became one team. So a team of gynae cancer surgeons from Hammersmith, Imperial College, and a team of renal pancreatic surgeons from Oxford. And we have actually genuinely morphed into one single team of uterine transplant surgeons. The title this morning is A Future Applicability in Cancer Care. Now, very sadly, all of you who are gynae cancer surgeons in this room, we are all going to continue taking uteruses out for many years to come and rendering people infertile. For some women in future, there will be an option of getting a uterus back again when they've been in remission for a suitable period of time. And that has the capacity, I think, to generate hope for quite a lot of women, which is a realistic potential hope. So the next slide, conflict of interest. As the chairman just said, I'm the chairman myself of Womb Transplant UK. Isabel is a trustee of that charity. We have no commercial interests in that, but I think it's worthwhile stating, and it does create issues with respect to the MDT. I'm also a founding member of the International Uterine Transplant Society. Now, this slide, collaboration, collaboration, collaboration. If there's one thing to take out of this talk, this has been decades of people collaborating with each other. And over that time, we've only ever rejected one offer to collaborate. Everybody else came on board. And you can see there, if you start bottom right, University of Bristol, that's surgical innovation. Lancaster, Cardiff's law and ethics. There's our veterinarian collaborators, tissue engineering, Stevens Group. And of course, the sponsors of the whole thing are Oxford, Imperial, Lister Fertility. What's this project been about? Compassion, compassion, compassion. I've been sitting in my clinic down at Charing Cross for years seeing women with absolute uterine factor infertility mixed amongst oncology patients. And that's kind of what's kept us going. And what this is all about is not transplanting uteruses. This is about letting women have a uterus and then have a baby. So I think one of the fascinating things that's come out of this whole project in terms of the surgical skill is that actually we're mixing together two distinct surgical skills. Most of you in this room, this is BGCS meeting, probably gynae cancer surgeons, and you take pride in removing organs with Halstedian principle of 1 centimetre of tissue, sealing vessels, minimal blood loss. That is not what transplant surgeons want. Transplant surgeons want organs without wodges of tissue around them and nice fresh vessels which have been tied off and can be stitched back together. And so the way this project actually works is that when it comes to the retrievals, I lead assisted by Isabel, who's usually saying, don't seal tie. And when it comes to the implantation, Isabel leads, and she does the vessel hookups, and we do the much easier side of things, which is the sort of support structures, vagina, etc. So genuine collaboration. So what's the size of the problem, right? Well, there's estimated to be 50,000 women in the UK with absolute uterine factor infertility. As we know, there's 100 to 200 women a year go down the route of surrogacy. We know there are 5,000 plus women with Mayer-Rokitansky-Kuster-Hauser syndrome. In other words, they've been born with no uterus, no cervix. They usually, in fact, have pristine tubes and they have normal ovaries. There's hysterectomy related to hemorrhage. And then, of course, from the point of view of this meeting, we've got hysterectomy related to cancer, cervical cancer, uterine sarcomas, gestational trophoblastic disease, and endometrial cancer. Now, for me, subject very close to my heart has been GTD, because I had the privilege to be the surgeon to the National Centre in Charing Cross for the last 30 years, handing over to Surgeon Sasso 2 years ago. And spin-offs from this uterine transplant research have been that we developed a modified Strassman procedure, which allows women with rare placental tumours to have fertility-sparing surgery and to preserve their uterus. And also abdominal radical trachelectomy came from this project, which is now done worldwide for fertility-sparing management of cervical cancer. And that was developed by myself, Laszlo Unger, and Giuseppe Del Priore. Finally, we've got benign conditions such as Asherman's, massive fibroids, etc. So if you're a woman who's got absolute uterine factor infertility, what options have you got? Well, you've got surrogacy, adoption, or uterine transplant. Surrogacy, you've got low physical risk, good outcome. Adoption, you've got low physical risk, you've got an opportunity to provide a stable home for the disadvantaged child. Transplant, you get to carry your own baby, there's no legal issues, and actually most of the ethicists regard it as many ways more acceptable than surrogacy, and it's clearly the only way you can gestate. But for all three of these choices, there's a lot of downsides. So when it comes to surrogacy, there's religious issues. If you're Muslim, Orthodox Jewish, you can't do it. Legal issues, obviously the adoption by the parents, the genetic parents from the surrogate, carries a lot of anxiety, although it actually very rarely goes wrong. It's country dependent, lots of places it's illegal, and there's emotional issues wrapped up primarily actually usually with what is the surrogate eating and drinking during the pregnancy. And I've certainly seen that with many of my patients worrying about that. And on the adoption side, well, it's lengthy, it's got a lot of legal ramifications, and the child may have difficulty adjusting. And then we've got uterine transplant. Well, let's make no mistakes, this is major surgery to implant the graft. You're then on immunosuppressive therapy for as long as your graft is in, and there's further surgery to remove the graft. And Isabel will go into this bit in a lot more detail than I'm doing. So from the point of view of those of you in the audience here who may want to refer to us in future, who at the moment is eligible, we've got to have absolute uterine factor infertility. Currently, you've got to have embryos created by IVF from your own eggs in cold storage. And we know the own eggs bit will soften in future, but that's where it is at the moment. You've got to be between 24 and 42. You've got to have no intercurrent medical conditions. Now, this is a really important point, right? Everybody else who moves forward to have a transplant is sick. If you're having a kidney transplant, if you're having a heart transplant, lung transplant, liver transplant, you are one sick person and you're used to being with doctors and being in that milieu. Our patients in general are not, with the exception of the oncology patients. And that's created its own issues for us as we've built our experience. You mustn't have a high BMI. If you've had cancer, you've got to be 5 years in remission. These are gynae cancers, and it depends on the cancer, not breast cancer, obviously. And it's envisaged women will have 1 or 2 babies. So we've been at this a long time. It was actually 97. Animal-based research. We did what's called Moore's criteria for surgical innovation, which is animal-based work, leading to surveys where we surveyed the public, surveyed doctors, nurses, etc., found reasonable support. And then 2015, we got ethics, but we took so long to actually get through all the approvals that we had to go again. Then we got COVID 2020, knocked us off for another 2 years, because people say, what the devil have you lot been doing all this time, right? Because it's taken us a long time. This is what we've been doing, right? And then 2023, we finally got properly going. If you look around the rest of the world, 135 cases, 2/3 living, 1/3 deceased, 65 live births minimum, and no issues for the babies. Majority of babies so far born from living donors. And the original retrieval times were 10 to 13 hours. Ironically, the Dallas group changed the technique, and the greatest irony for me was it's like an abdominal radical trachelectomy, and the retrieval time's now down to 6 to 8 hours, which we emulate. So here was the timeline. 2015, ethics, Ben Jones, Isabel. 2017, we'd got specialist nurses, ITU, British Transplant Society, the Royal College, Human Tissue Authority, National Advisory Group. Everybody said yes, but actually we weren't going. 2019, Prof. Ployg, Oxford, we were having a gin and tonic, not during a meeting, at the end of it, and he said, you guys have been made to jump through too many hurdles, so many hurdles, more than anybody. Just after that, we got approvals, we went live, but we were only live for 3 months, and then COVID appeared. So patient pathway, patients referred to gynae clinic at Charing Cross, assessment, investigation, psychological evaluations, then off to Oxford. IVF has to be funded by the patient or NHS, independent assessment, and then through the transplant MDT to be listed. Patient pathway, obviously, recipient suitability, IVF is Lister, uterus transplant is at the Churchill, and then joint management through embryo transfer 6 to 12 months later, Queen Charlotte's for delivery, family complete, completion hysterectomy at Hammersmith. That's the path. So there is obviously Isabel, who you're about to see on the podium in a second, Andrea, they did all that paperwork in Oxford, etc. Lister Fertility, huge supporters. And you see the Baroness Cox, Nick Mon and Nadine Caneva are patrons. We have a new patron, Christine Jardine, Liberal MP. We have been terribly fortunate. Without them, we would not have got where we've got to. And then down at the bottom, Neil Huban Media, John Harrison, Laurent Chaminade are publishing people. So uterus transplant in the UK, we've got a deceased project in situ, sponsored by Imperial College, proposal to do 10 deceased donor transplants. We've done 3, living donor, 5 cases, and we've done 2. We're one of the few units in the world who have got a living and deceased concurrent programmes. So if we look here, February 23, first living donor case, February 25, live birth, 5 cases performed, 2 living, 3 deceased. And as you can see, we've got 1 live birth, 1 recently performed, and we've got 1 ongoing pregnancy amongst our deceased and 2 undergoing fertility treatment. So there we go. Some of you will recognise some of the folk in that. There's a vast amount of people 2.5 years ago at that transplant. And you'll see in the very foreground there, there's lots of food, which was eaten over the course of a very prolonged day, 21 hours. That's the core surgical team there, and you'll recognise some of the folk from this society for sure in there. And post-op, scariest week of my personal career. We had no scope for this going wrong, and it was the end of week 2. We had 2 cervical biopsies, no rejection, and the patient started having a period, which usually means they will likely go on to have a baby. The follow-up is intensive. The big media issues, as you might imagine. There, of course, is roll the clock forward 2 years. We've got the group outside Queen Charlotte's Hospital, which actually got us all in a bit of trouble because we shouldn't have been outside in our scrub suits, but we didn't know that. And nobody told us until afterwards. There we go, little baby, a baby named Amy Isabel, Amy after the donor sister, and Isabel spelt the Spanish way, not the Scottish way, named after Isabel, who you're about to hear speak. There they are, family, really lovely family, I have to say. I always like this quote to finish with: success is not final, failure is not fatal. It's the courage to continue that counts. And I'm about to introduce you to hand over to a very brave and courageous surgeon, Isabel Quiroga. Thank you very much.
Well, thank you very much. It's lovely to be among gynecologists. It's not something that I had experienced until just a few years ago. I just want to take you back to the origins of, or the beginnings of transplantation, because we've been transplanting solid organs for over 70 years now. And the first organ, of course, life-saving organ, was the kidney. And then there was a long time, it was about 12-year gap between another life-saving organ was transplanted successfully. That was the pancreas and kidney, another as the treatment for diabetes on renal failure. And then during the 60s, we have this plethora of transplants, the liver transplant, heart transplant, pancreas transplant alone. This is just without the need for a kidney, and then a lung transplant. And then we ran out of life-saving organs to transplant. And it is not until 98 when we transplant something that transforms life. It's just like life-enhancing. And the hand transplant was very criticized at the time. And then the face transplant in 2005 is not just life-enhancing, it's totally life-transforming for those that need it and that can't leave outside, can't work or just be outside. And then we come to the uterus transplant, successful uterus transplant in 2014 done by Matt Branston and his team. And that is not just life-enhancing, life-transforming, but it is life-creating. And that is truly amazing, I'm sure you all believe. And in transplantation, in any other innovation, it does take a very long time for the procedure to be taken by others, about 10, 15 years, in which first we're just trying to figure out how to do the procedure successfully, but also how to manage these patients. And if I just take you to the experience of a pancreas transplant, for instance, and I'm sorry you can't see it very well, but even here, 12 years after the transplant, the first transplant was done, there's only about 150 transplants done in the world. And during the 80s, again, the uptake of the procedure 20 years later, 25 years later is low. But once you get to the 90s, not everybody, but quite a lot of people start understanding that these things do happen and they are successful. And transplantation, again, globally, totally different uptakes in the world, with the States and Spain having the greatest activity, but of course the UK very, very active in transplantation across the world, and there's continents in which there's either no transplant at all or there's no reporting of cases. And we do about 160,000 transplants, solid transplants in the world. And our experience in the UK, this is data from deceased transplants in general, but you can see here we have about 1,500 deceased donor transplants for which we get 3.5 or thereabouts organs. But there is still, I just want to say, please opt in for the donation, because there's still a huge amount of disparity of the need. We do 3,500 transplants, but there's still about over 7,000 people that need a life-saving transplant. So when we go back to what Richard is saying, 135 cases done in over 10 years. We are not in the infancy of uterus transplantation, but we are here as an embryonic stage. So the surgical technique, as Richard has referred to, we do living and deceased donors. So, of course, the amount of length of vessels that you can get from a deceased is significantly longer. But basically what we want is the uterine vessels. We leave the ovaries behind in the donors, of course, so there's no chance that any offspring is related to the donor. And what we end up is with uterine vessels. We then remove the fallopian tubes, and on the recipient, we anastomose the uterine vessels to the external iliac vessels, which is the similar technique that we do for a kidney transplant. And then Richard, of course, does his vagina anastomosis. The technique that Dallas has developed is using the ovarian vein, so we don't need to worry too much about that deep channel to get the uterine vein, something I knew nothing about until I started operating with Richard. But basically, the transplant technique is the same. So how did I get on to this this project? I have to say I lead the retrieval team in Oxford, and Richard needed a little bit of an understanding of how donation and the retrieval service worked. And when I was first approached, I thought, oh, no, that doesn't sound like the right thing. It seems like a step too far, having a transplant just to have a baby. And I went along with him and invited him, and so I used to organize the National Retrieval Masterclass. I met his team; they're all wonderful, but I'm still not quite sure if this is this right. And it was only when I met the first patient at a fundraising event at the House of Lords that I totally changed my view. I understood the need, and in that evening, my life, I have to say, my professional life changed completely. And now we have become this true collaboration in which the transplants are done by the two teams in Oxford. The follow-up is in London and Oxford, but the IBF and the obstetrics in London. So we did go through a huge amount of approvals. The Human Tissue Authority are the regulators of transplantation. So we had to change my license. We had to have multiple inspections until they gave us the go-ahead. NHS Blood and Transplant are the organization that supports transplantation, not in the living, but mainly in the deceased and donation. So the main concern is that we do not want to compromise the quality of life-saving organs. And then, of course, it felt like millions and millions of meetings in my organization, just trying to convince every single management point that this was right, and NHS England also gave us their approval. So as frustrating as everything was, I now understand it, and why. In the 90s, and we had already been doing kidney transplants for many, many decades, we used to tell patients that we had a immediate graft failure, technical failure of about 10%. Now we talk about 1%. When we talk about the failure rates of living donor uterus transplants, we're talking about 20%, and of deceased, 25%. Those are huge failure rates. Luckily, we haven't had any yet, but this could happen. And I'm sure that in years to come, hopefully in another 10 years or so, we will be maybe not around the 1% failure rate, but we are still learning, so hopefully it will be much lower. And yes, we do accept this is a non-life-saving procedure, and young women that are desperate to have a baby may not want to listen to what we have to say. You all understand the surgical risks, of course, but people on immunosuppression do have a risk, and it's a significant risk, an understandable risk of cancer and infection, as well as the medication risk that could have renal dysfunction, diabetes, hypertension, or bone marrow suppression. So what is paramount is that they understand what they're getting themselves into, and the consent process has to be watertight. And we started thinking, oh, they just come one day because they're healthy and it will be all fantastic. That's not how we now understand it. People need more time, and we need to visit the whole team and be fully aware of what they're doing. So in February 23, we did the first transplant. We did it on a Sunday. We didn't want anybody in Oxford to say, I missed out on my cancer operation because you guys were doing a uterus transplant. All the team was volunteers, and all the doctors and many of the other staff were doing this pro bono. And this is the team. These are the people that, I know Richard's just seen it, but shown it, but these are the team I work with every day, and I'm really proud of all of them. The operation was very challenging, as Richard said, but thankfully we had, this is the end of the many hours, and these are just my nurses, most of my nurses at the end of a very challenging day. And yes, what success is, you don't have, in other organs you have renal function and they tell you whether the thing is working. Here we don't know, we only have a viability of the organ by having a look at the scan. We monitor rejection with regular biopsies, and function is given by periods. But of course, ultimately, what we want is a baby. And when we had our first baby, that was truly an emotional thing. So the experience so far, just from me, this says it all. A very, very happy family, a very happy team, and seeing the baby for the first time was very, very emotional. it's a wonderful experience, but importantly, I think we now have a sustainable program. And for the patients, has given them a huge reassurance for those that were already in the program, for those that didn't know about transplantation, about their options. Now we're having more and more people coming through. And incredibly, hundreds of women have just contacted us, wanting to be a donor, wanting to be an altruistic donor and allow other women to share their experience of motherhood. And now I have come full circle, and I know that for some women, not for all, but for some women, this is the best option. And you, better than most, understand that women make very, very difficult choices during their lifetime, and they risk their livelihoods, their health in this dream of motherhood. So what we've done is we're giving an opportunity of parenthood to a few couples, 5 now, but we're giving hope of motherhood to many. And importantly, I think, is we're increasing the choices for many thousands of girls or women in the UK and in the world. And as Richard was saying, this is a huge team of people, and it goes very, very slowly, like in a movie, rolling credits, but it's a huge team, and we're very proud of everybody that had helped us through this journey. Thank you very much.
Really exciting talk. Questions from the audience? Okay, I'll start with a question. It's a very general question. So where do you see this program in 10 years' time in terms of uptake, and where is it going? This is like everyone, I'm sure, like has this burning question. Where do you see things in 10 years' time?
Yeah, I mean, I'll just get the microphone. Where are we going to be in 10 years? Well, we've already got a deceased and living donor programme which have kicked off. At the moment, things are funded by the charity. Wes Streeting, it has to be said, on radio 6 weeks ago, said that NHS could potentially fund this. There is interest, the Palace of Westminster, in this project. And in terms of money, we all know that the health service is short of money, very short. But actually, this is not big budget productions. This is actually relatively small budgets. And when we've got to where we've got with people working for free, but we've probably worked our way through over the 25 years about £1 million, right? That's not much money in the scheme of this thing. And each transplant is charged out to the charity at 25,000 for a deceased, 30,000 for a living donor. So this is potentially up there. The non-directed donors with altruism as well could give the third strand to this. As Isabel said, this isn't for everybody, but it is for some, for sure.
I have another technical question, forgive my ignorance. You mentioned that if you have a deceased donor, you have longer vessels. So how do you decide whether you use, I mean, obviously it's like availability, but what's the difference, the advantage of having a living versus deceased donor?
So I didn't, in the interest of time, I didn't go on to all these things, but obviously when you've got a deceased donor, there's no risk to the donor at all, so you can just get as much length of vessel without having to worry about, will I have enough blood supply to other pelvic organs? So it's mainly that, the availability and the length of vessels that we have.
So it's mainly a question for harvesting, but when it comes to transplanting, would there be a difference of transplanting a living uterus in a other?
Yeah, it's just mainly the length of the vessel, and
makes
we
it
can.
Easier.
Yeah, just at a very technical point, I might just get a little bit. If I get the anterior division of the internal iliac, then or a much longer length of that, then that might be more successful. I have to say we are changing our techniques, and I don't want to bore you with that, but it's just, I think that it probably ultimately is going to be the same, the length of the vessels, because we are just using a Carrel patch.
And we're also using ovarian vessels in the living donor.
Okay.
Right, so we don't go for because we get short uterine veins. It's that whole bit of the uterine veins around the ureter.
Yeah. That's fascinating, because yesterday we heard a lecture from Mario Latau about uterine transposition, where they severed the uterine vessels completely. And there are about 130 odd cases of those. And it does prove that leaving the ovarian vessel and sacrificing uterine appears to work for those cases. So there might be some correlation.
That's where I was coming from with the abdominal trachelectomy. Because at trachelectomy, the uterus is outside the abdomen. Cut the cancer off and stitch it back in, and it's only the ovarian vessels. And so, I mean, to me, it was when Lisa Johannesson from Dallas presented the fact they were using the ovarian veins for drainage. It's like, how come I could never have seen that myself in 15 years? Right?
We've got some questions from the audience.
Thank you so much. Excellent presentation. My name is Mavish. I'm ST3 at Derby. I think for gynecologists, we are more looking into fertility sparing now, especially there is much more talk about fertility sparing in early endometrial cancer in various different tertiary care centers of gynae-oncology. My question is that what are the updates of this specific cohort regarding the uterine transplantation? Have we already started looking at like what stage of the cancer or the characteristics, basically, what treatment they have received?
Yeah, thank you. So if you've had radiotherapy to your pelvis, you're absolutely excluded. That's first up. You've got to be current criteria 5 years in remission from a pelvic cancer, and you've got to have embryos created from your own eggs at the moment. That one, I think, will soften. So, yeah, we've got some quite clear criteria, and I absolutely agree that the drive should be firstly to fertility preservation, not going on to restoration by way of a uterus transplant. And the more fertility that can be preserved, the better, because this is a hard road for women to go down. And the fertility preservation aspect, you know, the trachelectomy, modified strasma, all the other stuff that everybody's doing, endometrial cancers with high-dose progestogens, etc., is all really good, because the less people that need to get this, the better.
Thank you.
Can I just say, I'm sure that in a few years' time, women having had radiotherapy will be offered a transplant, because we're only looking at the external, the external islet vessels, which are quite easy to get, or there's always a vessel that we could join. So at the moment, we are starting, and things will change.
Yeah. We have time for one more question only.
I am Polly, ST2 at St Thomas's. Building on that question, how come do we resect the fallopian tubes but don't yet use them for a natural conception?
So,
or is there research?
Yeah, no. So this is the greatest irony. So I didn't know until we started doing this that women, particularly women with Mayer-Rokitansky-Kuster-Hauser syndrome, all had beautiful fallopian tubes, because of course none of them could ever have had pelvic inflammatory disease unless it was hematogenous, etc. And I'm sadly of the age where we used to reverse sterilizations, before IVF took off. And we're actually very much thinking of looking at anastomosing the patient, the recipient's tube to the donor uterus, because that probably would have a 9 out of 10 chance of success, but with a 10% chance of ectopic. And that would become part of the counselling process. We're actively looking at that at the moment.
Ever the optimist.
Final comment from Chair. So over the years, those of who are involved with BGCS, you see Richard pitching up to give a talk on uterine transplantation. And every time people wonder, when is it going to happen? And when is it going to happen? And it finally did happen. And I think it's one of the greatest achievements that I've seen over the years, because I've been involved with BGCS over a long period of time. So we'd like to end the session saying thanks to both of you for this fantastic work.
So last but not least, I'm going to introduce our lovely colleague, Josna Pundir, who is a consultant gynecologist and subspecialist in fertility at Barts Hospitals. Josna will give us a talk in proactive, personalized fertility input in fertility-sparing management of cancer.
Hi, good afternoon, everyone. Thank you, chairpersons. That's a long title, but what Ranjit asked me to do was to talk about how we do the fertility preservation, but also how we do personalize it, and how we do take care of them individually. I am based at St. Bartholomew's Hospital Reproductive Medicine Center, and we are a little bit unique compared to the other assisted conception units in London because we do fertility and gynae reproductive medicine. So we have a big menopause center, gynae endocrine clinic, and fertility. So these fertility preservation patients actually come to us for fertility preservation, then some of them come to our menopause clinic as well. So we feel like we do look after them through longer time in their life rather than just the fertility preservation cycles. What I'm going to do is I'm going to talk about a little bit of the background and how the pathways are set up. And I'll focus a little bit about gynecological cancers because of your conference. Because when we're talking about fertility preservation, when I was trying to put these slides together, I realized there are a couple of different ways. One is the fertility sparing surgery, which really comes under your domain. And then fertility preservation in terms of reproductive endocrinologists, which comes into our domain. So I thought I'll split it up a little separately to give a flow through these slides. So then when I talk about fertility preservation, I'm going to talk about assisted conception side of it. I will just put a couple of slides on the late aftercare and late effects, and then conclude the slides. So just a little bit about statistics. More importantly, the one which I wanted to focus on is around 10% of all new cancers are in the reproductive age group, even though this age group really is not what I am interested in. I'm much more interested in 15 to 40. I do not do pediatric adolescent gynae, but more and more adolescent pediatric gynecology is also coming into fertility preservation domain. But roughly 10% of all cancers in the women are in this age group. Still, breast is predominantly at the top. But in terms of gynecological cancer, endometrial cancer, and then the ovarian cancer. So I'm just trying to put it in the context when we talk through these slides. And because the cancer treatment is evolving fastly and the survival has improving dramatically, the quality of life and the long-term side effects or the issues are becoming much, much more prominent to be addressed. Now, the loss of fertility could be secondary to any of these, either because of surgery or the chemoradiotherapy, but then the data suggests that fertility is one of the very vital issues when it comes to the women, especially in terms of their late long-term effects. Now, how does the reproductive function get affected? The most important thing, well, if they're getting surgery and if the ovary is removed, that will definitely cause infertility, but majority of the time we're looking at significant drop in ovarian reserve, which may eventually result in premature ovarian insufficiency, or straight ahead, she may become infertile because ovaries had to be removed. Removing the uterus is a different story because then you're talking about surrogacy or uterine transplantation. As I said, either it could be because of surgery or secondary to any of these. The important thing is when we look at the adolescent girls and hem-onc cancers, that's where, or even breast cancer, that's where it becomes much more relevant. The loss in ovarian function could be temporary or permanent. The problem with this is when it is temporary, they are getting more ignored because classically hem-onc patients, adolescent girls, they have resumption of menstruation and people forget about them. They totally forget about them that they could end up in early menopause in their early 30s. So this cannot be ignored. This is where we are at the moment when we know that she is going to lose fertility, we are referring them to fertility preservation to us. But this is getting completely ignored at this point. This is the fertility preservation guideline from the ESHRE group of guidelines, and literally everything is there. It's a huge document, but they have put lots of details in it. I have taken quite a few quite a lot of information from this because it's already there. It's a guideline. I don't have to reinvent the whole wheel. But I will break it down to our personal UK practice or to the practice in my unit. So first and foremost is the organizational setup. Now that is, of course, the most vital bit, how you're going to provide the service. And if you look at this, I mean, this patient, whoever is, who is diagnosed with a cancer, will go through a lot of multidisciplinary team people. First is the clinical care. Let's put as a gynecological team. Once they think that she needs fertility preservation, they come to reproductive medicine center. Here we have to have the channels of communication, bring them to the clinic, have a consultation, make a plan, and make an individualized plan, and then communicate with the remaining teams. And then, most likely, they may end up into oncology side of it. And then, of course, you got the follow-up and the late effects. But this organization setup, including all these teams and members and departments, is not that easy. In real life, when you put this together in a setup, the most important person is this. Honestly, they are admin team, band 4 or 5s, but they are the most vital people in the whole setup. Because as soon as the clinical care team contacts us, they prep the whole set, notes, come to us, they talk to us, they organize the appointments, they organize the investigation, they organize the counselor appointment, and then the patient goes through IVF treatment cycle or assisted conception cycle. But this person becomes really important, and the links between these people become extremely vital. The next problem is awareness. There is a huge knowledge gaps and barriers about the fertility preservation and the options which are available. Not only the public awareness, but oncologists, lack of referral pathways or specialists are not there. And then, of course, this is very much technical in a sense. All units may not have all the options available. So women, particularly, the data suggest that at the time of cancer diagnosis, of course, they're overwhelmed with all the stuff going on, and they struggle to think about fertility, of course. But they are also very much worried that if they delay, it may affect their cancer. However, their encounters with the physician is that the physicians brought up the risk of recurrence. They scared them. They assume that women has already got children, so she may not want it. They assume that the women without children or without a partner may not even want to think about fertility preservation. So there are just a few comments, but that's what women feel about their encounter. And there's very clear data that roughly as little as 10% to maximum 50% of eligible people are referred for fertility preservation. This is a new paper in the JAMA Open, and it again said half of the patients. So this paper hit the Washington Times. Even in a systematic review, it went from 0 to 85, but generally, roughly, only half of the women at the moment are discussed and talked about fertility preservation options. So there's plenty of things which need to be done still. What information do you want to give? There's a long list of stuff which has to be given, and woman is already in a very difficult place. But generally speaking, when we see them, we go through all these details. We take each appointments are more than an hour, and we give them repeated follow-up appointments as well. Of course, the guidelines put that all the specialties should have training logs about it. But how feasible it is, it's very difficult. When I said referral pathways, there are lots of practical difficulties. One is the structure of the hospital. For example, London, there are lots of hospitals. It's not like Derby or Eastbourne when there's only one unit. You got lots of hospitals, lots of specialities, lots of oncologists, lots of surgical team. So it becomes really difficult to reach out to everybody as much as we want to reach out to them and tell them we exist. It's not that easy. Second important thing is as soon as we get fertility the referrals, the patient has to be seen within 24 to 48 hours. Now that becomes a practical possibility, but we make it happen. this service has to be there 24/7, 7 days a week. We do have a fertility preservation lead. We have a second in lead, but all the remaining 5 consultants are always available to look after these women. So we always step in the absence of the other 2 consultants, and we do look after them, and we don't delay their treatment. When the patient eventually comes to see us, they come to see us for consultation. And this is very important to understand, because I'll show you our data that we had roughly 150 referrals last year, but only 60 went through fertility preservation. So that means remaining 90 patients, for whatever reason, had a consultation but decided, either they decided or we decided that we will not take them through. So we do give them a proper consultation. We look at their cancer diagnosis, the treatment plans, their age, their ovarian reserve, their existing family size, their future plans, whether they have a partner, etc. And we make literally every single person is a personalized care, because everything is different for everybody else. There's so many multivariables here. And then we make a plan to decide what treatment they are going to go through. So next bit is, what are the options? Of course, this is your field. You are going to decide which patient are eligible for fertility sparing surgery. This is again you guys. You put them on progesterone for early endometrial cancer. This was again surgical stuff, and this is radiotherapy. But GnRH hormones from the oncologist, the data is still controversial. There's no concrete data that it significantly makes a difference, but because it is a low risk, less harm procedure, we still ask the oncologist to put them on GnRH agonist when patient is going through chemotherapy. Endocrine therapies come in the remit of breast cancer, because patient is on tamoxifen. She needs a break. We need to know when. And if she gets a break, how long? Can she have a natural conception? Can she wait a year, or she should? So that becomes, again, very important, and we're driven by the breast cancer team. This is where we come, and this is where you come. Yeah. So fertility sparing surgery, easy. You want to keep the uterus. You want easy in a sense by the name of it. And you want to keep one or both ovaries as much as possible. And that's what you're trying to do. These are the guidelines. Everything is there in really details. Amazingly detailed guidelines are there, both for endometrial cancer and rest of the cancers. You are the experts, but I'll just very quickly take through. This is cervical cancer. This is where you are doing fertility sparing. They do not come to us, but they come to us. They come to us when they had a trachelectomy, and they do not get pregnant, and then they come to us. You're trying to do IVF treatment cycle, but you cannot do embryo transfer. You cannot find the cervical os. You cannot cannulate the cervical os. And that's when we have lots of dialogues with our gynae team. We try to do joint cases, we try to do EUAs, and we try to do the cannulation. This is the only place we see them. Then, of course, this one, so before they go to chemotherapy, then they come to us. But this has a small problem, this one. Because if they have spread of the disease in the vaginal vault, then for us to put a needle through becomes risky. And that's again where the communications keep going to and fro, whether it is safe, whether we can do it, and we're heavily guided by you guys. And just the post-trachelectomy issues. That's, of course, you try and transplant, but then we also talk about surrogate pregnancy. Endometrial cancer is easy. I mean, guidelines are all there. I'm not going to go through because you know it. But generally speaking, when the patients come to us, including endometrial hyperplasia and endometrial cancer, they're under remission. But again, generally, as you know, they're PCOS women, they're obese, BMI is high. And when they come to us, again, we are guided by you. Recently, we had a referral, and there's no urgency that I don't have to do a cycle within 6 weeks, but we are guided by you that how long, 6 months natural conception or 1 year natural conception, or you're worried enough for us to say get on with assisted conception, give her a baby. So we are guided by you, because funding is vague, because they're not immediate threatened of losing fertility. So we have to apply for individual funding for these patients, to say that oncology team is saying that she has got only 6 months and she has to go back on progestins. So this is heavily guided by you. So that's the interval. The reason is to reduce the interval. That's the only reason. Otherwise, their ovaries are fine. They're not getting infertile. That's the only indication, and that's why we apply the funding request for the same. Ovarian cancer is, of course, there's no way I'm going to go into it, because it's so complex, and we are so heavily reliant on you to understand who can have fertility sparing and who can have assisted conception. And we all feel very anxious if the cancer is on the ovary. Are we going to stimulate it? Are we increasing the risk? I'm putting a needle. I'm going to make it more disseminated. So we really, really talk to you all the time, and only once you are comfortable, we take them through. It gets very confusing in that way. So that is, yeah, so this is borderline ovarian tumors, and germ cell tumors are fine, but rest of it becomes quite tricky to do it. So I'm just going to now, the remaining slides, I'll go through what we do. So I'm just going to take you through a brief history of it. You know, in early 1990s, all we tried to do was to minimize the impact of cancer treatment by either pelvic shielding or doing ovarian transposition. Not much helpful, but that's all we could do at that time. And then came cryopreservation. So we could do embryo freezing, we could do egg freezing, the GnRH protection came through, and then oncofertility, the multidisciplinary team came through. First baby was born from embryo freeze in 1996 in the fertility preservation. In 2000 until now, then came the vitrification. So vitrification is nothing but a different technology to freeze these gametes and embryos, which is much quicker, better success, and better thaw. So that has really changed, particularly for the eggs, because slow freezing of eggs was very complicated and very difficult, and survival rates were not good. But vitrification changed the landscape of freezing the eggs. And this is what is happening. It's not just cancer. We are doing fertility preservation for lots of stuff. Gynecologists should be aware of endometriosis, particularly recurrent, all the autoimmune conditions, and quite a few. The list is really, really getting bigger and bigger. Ovarian tissue cryopreservation, as you know, that you take the cortex of the ovary and you freeze it, but in future you put it back in the patient as autologous, or some other person as heterologous, or you mature the oocytes in vivo, that is in vitro maturation. These are still in the developmental phase. The thing which has changed the landscape is also ovarian reserve testing. So antimullary hormone, when it came up and it started telling us the ovarian reserve of the girls, that also helped dramatically with this fertility preservation services in general and in fertility world. And then a little bit about how the protocols have evolved. And never forget, the alternatives are always there for the patients, like egg donation. So this is the summary slide, what we can offer today. And in real life, this is what majority of the people are able to offer. This still remains. This is a possibility. This is research context. Ovarian tissue cryopreservation is still, even though we have babies, it's still early days. This is the 99% of the work where fertility preservation happens. So we collect the oocytes, and then becomes, if she has a partner or if she uses donor sperm, we freeze the embryos. Otherwise, we freeze the eggs. If I freeze the embryos, she comes back later, we thaw the embryo, we put it back in herself or in a surrogate. If she freezes eggs, she has to come back. When she comes back, we thaw the eggs, we use the sperm to create the fertilization in embryo, and then that happens. So ovarian tissue freezing, at the moment in the UK, there are 3 centers which are providing, and there have been 3 babies in the UK so far. So we don't do it, but we link up with these centers and we refer the patients appropriately. Sorry, it looks like. So why are we interested in egg and embryo freezing? The main problem is embryo is the property of both the partners. And the male partner can withdraw the consent anytime. And it becomes a very sensitive discussion, but we do tell the girls all the time. If they come with a partner, we tell them very clearly, even if the partner is present, very clearly, black and white, that this is not your property, this is both of yours property, and the bloke can take away the consent anytime he wants. Whereas eggs are her own property and she can do whatever she wants to do with them. So as a setup, this is a very simple referral form. This is all what we need. So we have reached out to all the local centers, and this is our fertility preservation referral form. This is all we really need. When was the last period? What is the diagnosis? What is the plan? And what do you have in terms of timelines? How much time are you giving me to look after this woman? That's the main thing. Then we see them and we go through the whole of the initial assessment. Everything, her own individual risk of gonadotoxicity, her fertility, timelines, ovarian reserve. So we do antral follicle count, we do the scan on the same day, and we can do antral follicle count. AMH in the past used to take 2 weeks to come back. Now it can come back within 3 days, but sometimes we don't even have 3 days. So we do antral follicle count. What is her age? Because whatever is her ovarian reserve, her age is more important. Younger people, less ovarian reserve, do better than older people with good reserve. So age becomes the most vital bit. If the woman is already in early menopause or she's almost there, we have to tell the truth, and we cannot offer the treatment. And of course, the partner status. So NHS doesn't fund if woman is 43 or above. Even as a self-funder in our unit, 45 is our cutoff. In reality, in our unit, anybody more than 44 never had a baby with their own eggs. BMI more than 35, that's our unit policy, but UCLH is the only one who may want to consider operating on them, so we talk to them. We do decline the treatment. We do decline the treatment when the benefits, the risks outweigh the benefits, and we do liaise with their index team and to the patient. Patients find it very, very, very difficult to accept. What we feel is that when they're going through the cancer journey, they're in such a negative, anxious place, and somehow they hold on to this hope of preserving their fertility. And when we tell them that it's not the right way forward, they really get upset. And our counseling team really, really helps with us to take them to move forward. So that is antral follicle count. And these are the antral follicles, which are pre-antral follicles, which release AMH. So that we pick up on scan, and that we pick up on the blood test. And as I said, we assess the whole of thing, but generally the guidelines say that if AMH is less than 0.5, please do not bother, because it's not worth it. So just checking through the evolution of the protocols, traditionally, historically, we did long protocol. So the long protocol, you have to start the GnRH agonist around day 21 of the cycle, wait for the person to bleed, and once the menstruation starts or stops, day 2 or 3, you start the stimulation, and around 12 days later, you do egg collection. So we were dependent on the menstrual cycle of the woman, and the cycle used to take 4 to 5 weeks to get one cycle. Yeah? It had risk of ovarian hyperstimulation, because when you trigger with HCG. So those are the 3 main things against it. Then came antagonist protocol. So antagonist is your GnRH antagonist, which acts immediately, causing pituitary suppression, therefore suppresses spontaneous ovulation. So a person comes in, and as soon as her period starts, within 2-3 days, you can start both gonadotropin and antagonist together simultaneously, and can do egg collections in 2 weeks' time. It has two advantages. One, you're not delaying the premenstrual phase. Two, in antagonist cycle, you trigger the ovulation with GnRH agonist. You do not need HCG, which is the culprit of ovarian hyperstimulation. So antagonist protocols have dramatically reduced the incidence of ovarian hyperstimulation, almost 99%. So almost there. So this is the two main advantages of this. Then came the concept of multiple cohort of waves. It's quite fascinating. For 40 years, we thought you get only one wave of follicular recruitment. That's why we used to wait for menstrual period. But now what we understand is in the ovary, there are more than one follicular cohort recruitment happens, sometimes 2 or sometimes 3. So we are no longer dependent upon start of menstruation. And that paved the way for random start. Random start, because of this follicular recruitment, I can stimulate the patient anytime I want in the menstrual cycle. That's the traditional one, but depending upon where the dominant follicle is, I can start the treatment whenever she comes. This also paved the way towards duostimulation. So duostimulation is, that's a menstruation, I stimulate, collect the eggs, and within 5 days, I can have second cycle. So within 5 weeks of duration, I can have 2 egg collections. So again, if I had first egg collection, we reach out to the team and ask them, do you have another 2 weeks or 3 weeks? And if they say yes, we get on with the duostimulation. So you can have 2 egg collection procedures, doubling the chances in the same time frame. So just taking real-time data, we had 145 referrals last year. Average age was 33, but at least 21 women were older than 41. Parity, most of them were nulliparous. Average BMI was 26. But what I want you to see is this is the referral portal. So we do have huge referral units, and these are not even all of them. And then again, breast cancer remains the most common. And we started seeing transgender people. And this is the breakdown of gynae cancer we saw last year, borderline ovarian, endometrial cancer, 1 vaginal cancer, 1 cervical cancer, etc. But only 56 underwent stimulation. Half of them froze their embryos with their husband, 1 with donor sperm. Remaining half froze their eggs. 1 patient split into eggs and embryos. I just wanted to put this here. Why? Why the remaining 100 did not go through? Most of the time, patient has the consultation and they decide that they do not want to delay their oncology treatment and they want to get on with their oncology treatment. We might have said that, so these are all patient declined, yeah? We might have said that we will not take them through. I think around 6 or 7 of them, it's not here. But generally, it's about giving them the information, and not all of them go through the treatment cycle. Mm-hmm. Yeah, and the patient was menopausal, etc. Aftercare management becomes even more important because if fertility preservation is neglected, this is even worse. It's difficult. Who is going to authorize when and how? It is complicated. The most important slide, I think, is we do all of this, but the actual utilization of these frozen eggs and embryos is between 10 to 30%. Most of the centers say 10%. So only 10% of these women actually come back to use these eggs or embryos. And the reasons are plenty. But you wonder, you're doing all this hard work. The lab is, the tanks, half of the storage tanks are with these gametes, but only 10% actually come back. So I feel that this is the area where most of the research has to be focused, so you can utilize the resources to see who is actually going to use them. Finally, don't forget the POI and premature menopause. Please, that's the late effects. And that's it. Last slide.
So in the interest of time, we're not taking questions, but I'm sure Dr. Pundi would stay back for lunch, and those who want to ask questions can catch up with her. Thank you again. Thank you.